I'll tell now. Please take it off. Take it off. Ladies and gentlemen, as we are about to begin, I have a few notes to make before we could proceed with the program. I would request all of you to maintain complete silence in between the sessions as we are streaming the conference in the live, in the virtual platform. Also, I would request to keep your mobile phones in the silent mode to avoid any interruptions during the program, anticipating your complete cooperation in advance to make the program a success. The price of success is hard work, dedication to the job in hand, and the determination that whether we win or lose, we have applied the best of ourselves to the task at hand. Good morning, Excellencies, distinguished guests, senior consultants, nursing superintendent, deputy nursing superintendent, delegates, and my fellow colleagues. It's my pleasure to be moderated for today's conference. I'm Archana.
I'm Vidya Seri.
And on behalf of the entire MHP nursing team, I would like to extend a warm welcome to all of you to the state level Oncology Nursing Conference theming Oncology Care Model. We appreciate you taking time off your busy schedules to join us today and hope that you will learn a lot.
As we welcome you with a dance, let me take your attention to Mother Nature. Nature blooms with life, with birds singing, dancing deers, and jumping fishes. All are happy in their own surroundings. Let's connect our life with nature and feel the joy, happiness, and bliss. But every day is not happy for them. They too have their own dangers for survival. In the same way, in our lives too, darkness can set in many forms, maybe as sickness also. But just like nature is dynamic, we too overcome our problems, sorrows, and diseases. Today, through this dance, we want to pass on the message that every pain will pass on.
मन मंदिरा ते जाने ओ मन मंदिरा ते जाने उजड़ो करा जबरदस्ता मन मंदिरा ते जाने उजड़ो न के सदका मन मंदिरा तळहाताच्या रेषांनी सहज सुखाका भोगी कोणी तळहाताच्या रेषांनी सहज सुखाका भोगी कोणी स्वयं प्रकाशी तू तारा चैतन्याचा गाभारा भर पंखातून स्वप्न उद्याचे भर पंखातून स्वप्न उद्याचे झेप घेरे पाखरा उजळून घे जादगा मन मंदिरा दे जाणे उजळून घे जादगा मन मंदिरा मन मंदिरा मन मंदिरा
Kindly request Ms. Vidya to welcome our dignitaries and our guests, starting with Dr. Manish sir with a floral bouquet, and escort him to the dais. Thank you. I request Sister Asha to please welcome Dr. Shankar and escort sir to the dais. So Dr. Shankar has left. So Sister Asha, please welcome Professor Dr. Somashekar, and please escort him to the dais. Thank you. I request Sister Vilasini to please welcome Dr. Poonam Patil and escort ma'am to the dais. Thank you. Requesting Sister Shanta to please welcome Dr. Ashi sir and escort sir to the dais. Thank you. Requesting Sister Maggie to please welcome Judith ma'am and escort ma'am to the dais. And lastly, requesting Nagamani ma'am to please escort our KNC observer, Ms. Linta Mol, and welcome ma'am to the dais. Thank you very much. It is indeed a visual treat seeing everybody dressed up in purple. I didn't know purple was such a beautiful color. So thank you very much for accepting the theme and coming forward. I also like to welcome B. Brown, who is the sponsor for the conference. So once again, from the depth of my heart, welcome to each of you who have been gathered here. I believe this conference is going to really help us understand care of patients with oncology or onco diseases. Thank you each of us for coming, and a very warm welcome to all of you. Thank you.
Light is a symbol of brightness and prosperity, as sunlight expels the darkness of light. To make this event a blessed one, I would like to invite Dr. Manish, Dr. Somashekar, Dr. Poonam Patel, Dr. Ashish, and Onco champions along with Ma'am Judith. To kindle the Kuttuvilakku, request all the nursing leadership team to join for the same.
Thank you all for joining. Thank you all for joining. Now I would like to invite Dr. Manish to speak a few words on this occasion.
Very good morning to all the delegates, and I think it's such a joyous occasion to see such cheerful faces early in the morning. I would want to heartily thank our consultants who have also taken a lead role in designing and delivering few of the key lecture notes. I'm aware that we will be speaking on a lot of key themes in this state Oncology Nursing Conference. Enhanced recovery after surgery, pressurized, hyperthermic, intraperitoneal chemotherapy, the role of neutropenia, how do we deal with it in onco patients, and also the care which is given to onco patients, which is very different from the run-of-the-mill patients that we see in the hospital. So this is a great opportunity for us because we are now face-to-face, not only in a physical format, and which to me is a great boon. You know, I'm seeing this kind of a setup after a 16-month hiatus, but we are also saying hello to many of our colleagues on a virtual platform. I would request all of you to make use of this opportunity, really delve deep into the lessons, into the experiences which the subject matter experts will be putting forth before you, and make this a very live and engaging session. Wishing all of you a great conference ahead. Thank you so much.
Thank you so much, sir, for your enlightening words. Moving on to the highly awaited sessions of the conference, I would like to invite the very dynamic Dr. Poonam Patel, Consultant Medical Oncology, Manipal Hospitals, to unfold the theme of oncology care model.
So good morning to you all. A very warm welcome to you all today for the Oncology Nursing Conference. So today's workshop is organized with a purpose. It is an initiative to improve oncology care of patients and define nurses' role in the initiative. I have no hesitation in saying that nurses are indeed the backbone of every hospital and definitely of our hospital, but within them there is a cherished group. I must accept that I am partial to oncology nurses because they are the best, and their care, besides their nursing expertise, also extends to empathy and sympathy that they give to the patients. So we are very proud of them. However, our profession is such that it is always evolving and learning never stops. So this workshop will help you learn strategies to improve your efficiency and also increase the efficacy of therapy. It will give you an insight to think how better can you provide care to the patients. Of course, hard work is important, but it should also be effective. So your work becomes more efficient with better time management. So you have to redesign your activities in such a way that optimal holistic care is given with continuous improvement in quality, and hence there is no compromise in patient care, and you are also able to carry all your duties very efficiently. Today you have many aspects of patient management being discussed, with some knowledge about the common procedures being performed, discuss everyday challenges faced by us all, and by the end of today's workshop, you will all be inspired to be the drivers to change patient healthcare for better, especially with reference to oncology. So now sit back and enjoy all your talks today and enrich yourselves. Thank you.
Thank you so much, ma'am, for your encouraging words. Now may I invite a very renowned and versatile Professor Dr. Somshekhar SP, HOD and Consultant Surgical Oncology, to share his excellency on ERAS pathway.
Lights off.
Yeah.
Height is not comfortable. Thank you. Thank you very much. It's pleasure to be here. You know what stands apart in the Manipal group for us? A lot of doctors get undue credit. You know, we are known as a center for advanced, complicated surgeries which nobody in country or town are able to take, and Manipal is known to take such cases and give good result. falsely, most of this credit actually goes to the surgeons. But a good right-minded surgeon knows doing a surgery is only minuscule part of the entire treatment. The most important is the care what follows after. There are million surgeons better than us in this world, in India, everywhere. Million setup which is available, but with all humility, humbleness, experience over past so many 3 decades, everybody knows, and I have realized the fact a patient can go home depends entirely on what happens after patient is wheeled out of OT, and that is entirely in the hands of nursing. Ever since I have joined, this August it's going to be 20 years of me, I have always felt proud and safest to operate in this institution than anywhere else in world. I have operated in US, UK, Australia, Paris, most of the centers I have worked across the world, but the safest place for a patient, if I am a patient, is here because of the nursing. That is exactly the reason. When a patient walks into me, they come with the aura that somebody has referred. They say, okay, you go to the best center, you're going to go to Manipal, Dr. Somcha is going to take care. I always tell them, what makes a difference for us that you go home is the way a nursing care is done. It is selfless. And you know what? A surgeon has always some conflict of interest, because when you do that, you become a demigod, you get a name. But there are hidden people who are behind, who contribute to the success of that patient going and the entire team, and that is the nursing. And one of the best care we have right from, nursing starts right from pre-op. Pre-op, how they work with our nutritionist, how they take the patient in my ward, in my OPD, then how they care in OT, who helps us and assists us. In a span of second, surgery is like a million movies happening in split of second, and surgeon can always ask, but a nurse assisting me knows every step what is there. They have got about over 20,000 instruments, and they need to know what needs to be given to each surgeon at what step. Then they come to post-op, then they go to ward, and many times you have seen that, anybody who gets into hospital, it is not the husband, wife, children who take care. They just think that I come, pay the bill, and I just sit with them in the neighboring area. Most of them run on computing mechanically. Nobody knows. Only the nurse knows. When I take round, I may have 5-10 doctors with me, but I always trust only nurses' words. Because I know my doctor comes for an hour, will look at what nurse, and if you ask them, what they say is 100% truth. They have passed the journey from 8 p.m. to 8 a.m. morning with the patient. And that is what actually takes them out. And this is something which we have noticed, taking complex patients, cancer patients with empathy, and they go home. And in logical extension of this, when as a Manipal group, we decided we should be one of the first in Asia, not only to give a benefit of good result, but to make a patient go home. The motto of me is, a patient should sleep on their bed in their house every night. So get them morning, do a surgery, robotic or whatever, try to see if they can spend as less time on the bed of hospital and more in the home. So this is one of the reasons now Singapore hospitals has taken, and other hospitals in India are coming, but we are the first people who adapted ERAS. What is ERAS? Enhanced recovery after surgery, when we implemented in colorectal, gynec, and a lot of other people. So what is the genesis of this? This is the main thing. Professor Henry Caillet, he is the guy who thought, when you go for a rounds, you have 50-60 patients, post-op ward, ask one question to yourself, why is this patient still today? Have I finished my surgery? Yes. Why is he? Did I do a wrong surgery? Did I do a complication? Am I not fit the patient before well? Or am I afraid of complications, so I want to keep the patient? So what is the business of that patient after surgery to be in the bed? Are we not using multimodal care system where I can send the patient home? Remember, when a patient gets into the operation theatre and into the hospital, it is not the doctor, bed, precious bed, and the nurse who is helping them. All are tied up with that patient, the more they stay. If a patient is running on IV fluids non-stop, changing the drip every 4 hours, 6 hours, because there is a line gets blocked. Imagine how much you are overburdening and wasting the system and giving complication. More lines, more IV fluids, that many complication. So how to reduce the stress response? Now we all know that the whole component in the body is insulin resistance, interleukin 6, tumor necrosing factor, and these stress hormones. They are the one which cause infection, they are the one which cause pneumonia, they are the one which cause all the problem. Forget the cost, because a nurse can treat 10 patients on a day, or the same 10 patients for 10 days. What a natural waste of disaster pool. You know, you can get doctors easily, you don't get doctor. That's why attrition among nurses is very high. You want to go to UK, US, Middle East, first nurse, last doctors. That shows the value of a nursing system which I have under. So now we will see, even though for me, the cure of surgery, aim of surgery is cure, no complication, easy recovery, these needs to be totally applied by different. Because a happy patient is one who has a shortest hospital stay with lowest complication. But as a healthcare worker, when we put, you know, we always put this X and Y axis. In any treatment in hospital, be it dialysis, be it cardiothoracic surgery, oncosurgery, CT scan, MR, should have this positive balance. Low cost, maximum effect. You know, there are some unfortunately which are high cost, low effect. Dialysis fits into that. That patient is going to die eventually unless you do a liver transplant. Every day, 3 weeks a day, they are there. How much money they spend under complications. So it has been analyzed by NHS that there are some treatment which fall into that maximum. I'll give you one example. A simple tablet aspirin. Your headache is out, inflammatory response is out for peanut, and you go back to your work. Look at the positive effect and the cost. So we need to see all our surgery fall into that X and Y axis, and how do we do that particular area to achieve that particular thing, and that is where actually we get this ERAS. What is ERAS? It helps for fast recovery, few complication. See, how does the complication come? You may do a good surgery, multiple lines, thrombophlebitis fever, because there is an IV line, patient doesn't walk. Because they don't walk, hypostatic pneumonia. Because they don't walk, there is a calf muscle stasis and DVT. And because there is an IV line, drip is running. Because there is a drip running, they are not eating. Because they are not eating, hypoproteinemia, hypoalbuminemia. Imagine how everything unnecessary is tied up. Many times patient doesn't know that, oh, I am not allowed to walk. If there is no IV fluids, if there is no line, if there are no tube, day 0 you make them eat, how much free nurse is? Instead of changing the drip of all 10 people, they can attend an eligible patient, somebody who needs a tracheostomy care, somebody who needs a dressing, somebody who needs a nutrition. And because there are no lines, no antibiotic required, no analgesic required, patient has no business to stay next day, they just go home because they are on oral feed. So shorter strength, lesser complications in the complex, reduce the workload on the nurse and the healthcare professional so they can attend the better people. I'll give one example. Filling the hospital with all asymptomatic COVID patients. What a natural disaster and waste. 99.9% patients become all right. We have to try out those 0.5% who are to come. But what happened in first wave? All asymptomatic sitting and happily in home. What are you doing? Saying, how are you? 14 days. Because they can't go. That is the natural disaster of keeping a surgical patient in IV fluids tube and telling a well-trained professional, very important healthcare worker, nurse to manage that patients. If there are no tubes, no IV fluids, do a good surgery, good nutrition, ambulate them, send them home. Workload on the system is very, very less. And then imagine the impact on the cost we save. The whole concept is to reduce the stress response. Stress response reduces complication. That reduces length of stay. Further treatment, remember in oncology, surgery is only one part. If my patient doesn't go for chemo radiation on time, every week they go late to chemo radiation, they lose 1 month of their life. So how do they go early? I send them home early with low complications. See how all are interlinked. How nursing, surgical team, nutritionists work together. Correcting malnutrition, stress response reduction, quality of life, and then cost and program. I always believe that you do a good job, cost automatically comes. Don't target the cost, then you cut the corners. You take your benchmark and you are increase by notch your quality of other aspects. As a corollary, proof of pudding is cost naturally should come down to you. Like, I'll give an example, open surgeries, 15 days, 5-hour surgery, lying with tubes. The moment we switched over to robotic, daycare discharge, no tubes. Naturally, if you are doing a right thing, when you analyze the cost to the health system and patient should come down, it will come down, which we analyzed in ERAS and also we analyzed in robotics. So how do we work towards this ERAS in removing this? So I will show you how we went. You know, naturally what happens, you tell a patient you fast 2 days before, you take oral purgatives, they get flushed up, they are on liquid diet, they are already malnourished, stress response has started, then you do a major surgery, multiple tubes, patient cannot walk, they said they need 5 people to lie down, nurses has to take care of the fluids tube every day. Finally, eventually one day, you know, they just go home on this day, and when they go, 14 days typically. Now imagine if you can apply ERAS. The fast track ERAS trial showed that if you apply ERAS, a patient would go home in 3 days, length of stay is half, and complication is less. Is it true? Is it really true? So we need to see what happens. Our old concept, fluid restriction, wrong. In our hospital, 2 hours before a surgery, energy pre-carb drink is given to patient. We got a formula from Nestle. We approached the ISRO Nutrition Center in Mysore to make it low cost at 100 rupees for us. We purchased in bulk million of them to our pharmacy. What costed 1000 rupees we gave 2 hours before. When you run for a marathon, your best player, will you tell you fast overnight, morning you take purgative, go for Dalcolase, get on enema, don't take anything, starve yourself? What marathon? Even before the ox pulls the cart and ox are dead. So we have changed that concept. All our patient 2 hours, you know what our patient love? Morning I have energy drink. Are you really laughing? I underwent surgery 2 years back in that hospital. They fasted me. They told nothing to take overnight. Then surgeon, when is free, OT available, 3 o'clock surgery, next day morning first feed. Cruel not to give by mouth. In our hospital 2 hours before surgery, energy drink is given. Imagine how refreshed you feel. It is like a very, very cold chilled water, you have it. Then we use regional anesthesia, try to use more of nutrition day 0. Our nurses, they have an energy drink. We have prepared a special energy drink. We don't give bowl preparation. We don't put tubes. We don't put catheter. Because there is no catheter, no infection. Nurses' job morning, if you go and see input-output chart, surgeon, they hate us. 1 tube here, 1 tube here, 1 tube here, tube 1, you output, tube 2, output, empty them. What is nurse doing? Clerical job of a man, come down. So when we adapted ERAS in our hospital, look at this. Patient eats well. I tell them enjoy, eat full meals 1 day before. Morning they have energy drink, nutrition taken care. Day 0 our nursing team mobilizes them. They give oral feeds. They have feed, and then look where they go. Instead of weeks, they go in days. If it is day, they go in hours. And all the complications, nausea, vomiting, everything typically come down. So how do we fast track? You go to any hospital, everybody is very happy. You know what they say? No, we do ERAS, we do ERAS. Everybody says, I do ERAS. Are we really doing ERAS? So we need to look at it, what was the experience. I also thought before we got, involved, we are lions on the thing. But then we audited, reality was totally different. When we looked at our audit, look at ERAS. We thought last 20 years we are doing ERAS, and look where we were. 7.4 days. Our patient going, complication 15%. There is something wrong. That is when the hospital manager intervened. Our nursing team, nutritionist, anesthetist, all the surgical team, we got trained in ERAS. We do every week ERAS meeting in our hospital. And then we started applying this ERAS protocol. And because of that, you will be surprised what happened. All these are done by nursing. 90% of the work is nursing staff, and then the anesthetist, and there is an ERAS specific coordinator. Everyday data is uploaded on a Sweden website, not by us. So there is no manipulation. This is what we got it done at few hundred rupees. This is what our patient immediately, as they are conscious, they open, shake, and they drink this. Immediately post-op. Don't wait for bowel sounds. Then we published our study in an international journal. What did we find? Look at this. When we applied ERAS, after just 1 year, we brought our complication less by 50%, and then we brought it down to 3 days. And then I will show you this curves given by Arjun. Major colorectal cancer, 7.8 days, we came to 4.6. All the nausea, vomiting, everything came down in the patient. The cost came down by half with compliance, and this could be achieved just because of, look at this circle, we have achieved 90% of compliance. And what was the impact of this when we did a cost? Per patient, about $1,000 we could save by applying ERAS. And the nursing load came down by half because there are no tubes to follow. So in conclusion, I want to say the compliance and the nursing component to the ERAS is most important for us to have a successful team. Reducing stress, complication, readmission, cost, not just length of stay, and also bringing down the complication. So this is what is an experience, and the great success actually is given by our nursing team, and we profoundly thank them. Thank you very much.
Thank you so much, sir, for the encouraging and remarkable session. Now, may I request Ms. Judith Watson, the nursing superintendent, Manipal Hospitals, to honor Dr. Manish, sir, with the memento. May I request Ms. Nagamani Dara, Deputy Nursing Superintendent, Manipal Hospitals, to honor Dr. Somshekhar with the memento. Thank you, sir, and thank you, ma'am. Next, coming up, an interesting session on febrile neutropenia. May I call upon the very eminent Dr. Ashish Dikshit, consultant hematology and bone marrow transplantation, to take us through the session.
Thank you very much. And as Dr. Poonam mentioned, the nursing staff, oncology nurses are the backbone of the hospital, backbone of our department. I would rather go one step even forward. I would say they are the very soul of the department, because the entire department runs on our nursing care. That's the very reason why we are successful. And essentially all the work, everything, whatever they do, is the one that makes us one of the best in the center and the country as well. So the second part was mainly from the talk that Dr. Somshekhar gave. He is mainly emphasizing on the short stay in the hospital. I definitely want him to do that, because the shorter stay, the nursing staff should be available for us to use, because most of the patients in the medical side are going to stay for a longer time, particularly in the medical field. So we are going to take you to a different level altogether, where most of the people actually need to stay longer, and they need longer nursing care as well to make sure they can survive through that entire ordeal. So we'll discuss about febrile neutropenia. Now, the febrile neutropenia is what we are going to discuss is mainly what is the definition, what exactly we do, and why exactly it is so important to pick up early, to make sure that we act faster, to make sure that what all things we should watch for from a nursing point of view, why we take one decision as a doctor, and why the medications and other things have to be changed, so that we are oriented towards it and be careful whenever the new signs or symptoms arise in any patient. So to put it just as an introduction, fever may be the only symptom in a patient with neutropenia, and before the advent of antibiotics, the mortality was as high as 70%. The problem with the febrile neutropenia is most of these neutropenic patients, the inflammatory signs are more or less attenuated. So you will just see fever, no other symptom till the time it is very late and you don't act on it. Nearly 80% of these hematological malignancies what we deal with, or for that matter a bone marrow failure syndrome, will develop febrile neutropenia. So what we need is prompt initiation of the antibiotics, and that should be done on time. If we look at the incidence, being a bone marrow transplant center and a hematological malignancy center, what we see is common. It's very common amongst the autologous and the allogenic transplants that we take care. And during graft failure, it becomes all the more important because the patients are going to be neutropenic for a very long time, lasting more than 1.5 to 2 months sometimes. Cases with acute myeloid leukemia can be neutropenic, can be having febrile neutropenia in around 40% of the cases right at the time of diagnosis. ALL usually has a less common incidence, around 30%. What we need to remember is the mortality related to febrile neutropenia. It is as high as 10% to the autologous, for the autologous transplant in the centers which are not very experienced with it. It comes down to as low as 1% or even below 1%, as you have seen over the last 15 years in our center. It's highly variable in allogenic transplant because it depends on what is the primary disease we are dealing with. It becomes very high in graft failure, as we discussed. It is up to the tune of 20-25% in allogenic transplant related to either sepsis or complications related during the transplant. And during the induction chemotherapy of ALL, the mortality risk is much lower. And again, it comes down to the experience of the center. The mortality rates that we see again in ALL is less than 1%. So let's come down to the definition. There are different guidelines that have been proposed for that. One is IDSA, one is by NCCN. Both the guidelines more or less mention the same thing that we need to remember. Fever which is developing in a neutropenic phase, single temperature of more than 38.3 or 101 degree, or if it is sustained more than 38 degrees centigrade or 100.4 degree Fahrenheit over a 1 hour period. It is less common in solid tumor unless they are again severely neutropenic based on the type of chemotherapy. But in hematological malignancy, you will see nearly in everybody. The neutropenia is defined as the absolute neutrophil count below 500 here. So the syndromes of neutropenic fever, they are of the they can be three different types. One is microbiologically documented infection, where it is a clinical focus of infection and an associated pathogen that is also identified. The second type of syndrome is clinically documented fever, where there is a neutropenic fever, there is a clinical focus like a cellulitis or a pneumonia, but you don't have any microbiologically isolated organism. And third is an unexplained fever, which we usually deal with in most of the time because the common source is not identified. So this is the fever with neutropenia, neither a focus of infection nor identified pathogen, and that is one of the nightmares when we face whenever a patient starts developing it. So majority of the cases, infection etiology is not identified. Proven infections are seen only in 30% of the cases. Most common are bacteria, fungus, viral are relatively rare, but something that we do come across off and on. Almost 80% of these infections come from within the body. So what is important is try and prevent these 20%, and that's where we are heavily dependent on our staff to make sure that we encourage these control of these exogenous environment to make sure that infections don't come from outside. That's where the importance of mouthwashes, sitz bath that we keep stressing upon for the care of these neutropenic cases comes in. So what are the common bacterial pathogens? They can be either gram-positive, which can include staphylococcal group, coagulase negative, or Staph aureus or Enterococcus group of organisms, or it can be gram-negative organisms. Host of it, I think all the names what I have written there, we see once in a while in one or the other case, whosoever comes to the hospital. Thanks to our excellent microbiology team, we do see much more positivity of the cultures in most of the infection cases that we see. And all these names are fairly common to see in our population, as in our patient group also. So what we have seen across the years over the period of evolution is in 1960s and 70s, it was mainly gram-negative infections that were common. As we developed antibiotics, we started learning about it, we started controlling, then gram-positive started dominating. Particularly because we learned how to use the catheters as well. Then came 80s and 90s when again gram-negatives started coming in, and that is because we have used rampantly the antibiotics for every particular need. Very rarely we came across fungi and mold. So this is just the changing etiology of the bacteremia that we have seen. Gram-positives were dominant earlier, more commonly because of the mucositis. Then the gram-negatives came in. Now why the gram-negatives are again coming back? Because we are developing more mucositis, there are more catheters that are there, and there is selective antibiotic prophylaxis, plus we are using a lot of antacids. We reduce the acidity of the stomach, leading to promotion of the organisms developing there in the intestine. So these are the recent trends. We are seeing more graduate scores, mainly to make sure that it becomes different from the regular understanding of it. So there is a score called Multinational Association for Supportive Care. Complicated score, but simple way of understanding is it depends on what is the primary illness, how bad is it, whether there is any hemodynamic instability, any underlying comorbidities, and the patient age and the burden of the disease. Based on that, a scoring will be given. A high score becomes a low risk. It's the contrast. A low score becomes a high risk. So that is where we can segregate the case and then identify whether that needs to be treated more aggressively or outpatient basis. Similar score that is more developed for solid tumors. This is clinical index of stable febrile neutropenia. It included what is relevant to our population also, included the one with the diabetes also, the one with cardiovascular disease also, severity of mucositis that we see. Based on that, scoring is given, and this is easy to understand. More score, more risk. So the high risk criteria also included the neutrophil count, which is dropping below 100, and this is something we see very often in a bone marrow transplant, or in the cases where the neutrophils drop much early after the chemotherapy and we expect it to last beyond 7 days. If it is in association with the other comorbid conditions, severe mucositis, if there are other problems related to hemodynamic instability, or there is a focus of infection identified, these all make it very complicated to manage for these cases. The low risk criteria, what we follow is less duration of neutropenia, no comorbid or other conditions, and stable person. A high risk criteria, in addition to cytotoxic therapy, the degree of low blood count, risk scoring as per high risk criteria, and certain type of therapies including transplants and the newer therapies like CAR T cell, or the therapies which are too immunosuppressive, progressive cancers, or a liver failure, which makes most of the cases decompensate very fast. So what we need to see when the patient is getting admitted, and what we are looking at from a nursing point of view, to look at, first look at the catheters. Make sure that the entry point is clean, it's hygienic, it is looking fine, and that is not the source of infection. Look at the symptoms and sign. You can always alert a doctor in terms of a new symptom coming in. Somebody getting admitted, the alert should go as early as possible to the doctor whether the patient has any respiratory distress, anything that is there on the skin, a cellulitis, a boil, or anything. That will be a relevant feature for the doctor to take action and identify which particular antibiotic to use. Put an attention to particularly perineal region, any genitourinary discharge, because they are the most dangerous ones to control. In addition, the neurological status, whether the patient is conscious or not. It's important to know the previous microbiological cultures. So this is the part we usually will keep seeing, but it is important to basically look at what was the previous cultures positive and whether it can correlate. We need to do urgent screening. The investigations are the one standard. We do complete blood count, liver, kidney functions, cultures to be taken from all the lumens of the catheter as well as the peripheral line. Usually that is what we follow. Urine culture is required in select circumstances that we will always ask if there is genitourinary symptoms also. Skin lesions, we may need to take a swab. Further investigations are dependent on the symptoms. So we may ask for a CT scan if the patient is having respiratory distress. We may ask for a bronchoalveolar lavage if the patient has got respiratory symptoms. So any of these sources may help us decide which particular way to go, and the staff particular role is mainly to pick up and then make sure that the attention to these areas go much earlier compared to what the treating team can actually identify, and that's where we are heavily dependent on our staff. So how do we manage, and why it is important for us? As we have told, there is a high mortality. The moment the patient comes to hospital, we are all very scared that the patient has to be, the first antibiotic should be given as early as possible. So this is a simple algorithm. Febrile neutropenia, we just decide based on the low risk or high risk, depending on the scoring or general scoring model that we find. If it is high risk, patient has to get admitted. Immediately the first dose of antibiotic has to be given. If it's a low risk, we will either decide an outpatient basis care with the oral antibiotics, or we may decide to just observe, watch, wait for the culture report with the oral antibiotics, and then wait, or to step down on to the oral antibiotics after the initial admission. So the timing, as I said, is crucial. It should be initiated within 1 hour. From the time patient has come to hospital, within 1 hour the culture should be through and the antibiotic first dose should be given, and that's what we usually need the staff to always make sure. If it is not available within that time frame, somebody has to alert urgently to us. The empirical antibiotics depend on the center choice. So most of the time what we use is third generation cephalosporin, aminoglycoside, depending on the situations, a combination of the two. Low risk, usually we use oral antibiotics, common amoxiclav with oral levofloxacin or ciprofloxacin. Now, things change when there is pneumonia. So if there is pneumonia, we need to decide whether it is a scenario where significant neutropenia is there. We need a good gram-negative cover. We need a good gram-positive cover also to cover for mainly the Staph aureus. We need to make sure that we cover atypical organism depending on the immunosuppressive drug that we have used. Sometimes we need antiviral therapy, particularly in a bone marrow transplant scenario where antiviral, the viral infections can dominate in particular phase of the transplant. Antifungals are something that we definitely need in case the CT scans show features like a fungal pneumonia. Same protocol in gastrointestinal symptoms, but here it is predominantly gram-negative and anaerobic cover that we need to use. If there is significant diarrhea, and that's where we need the attention immediately from the staff, that we need to send for a Clostridium difficile if the patient has been exposed to antibiotics or has been exposed to antibiotics in the recent past, and there is significant diarrhea with neutropenia, because there we need to definitely do oral vancomycin only. What about the catheters? Some part of the catheters that we need to remember, not every infection need to be removed, need to require a removal of the catheter. So we do not need to remove if there is a simple infection. If there is a limited exit site infection, we can very well salvage the catheter. The way we identify the catheter infection is we do differential time to positivity. So we will take cultures from both the lumens and we will take culture same time from peripheral line. That's what we usually tell everybody. Whenever there is infection, we need to know what is the differential time. If there is a 2 hours gap from a catheter sample and the peripheral sample for the growth of the organism, that indirectly tells us, yes, this is possibly going to be a line infection and the line has to come out if it is a gram-negative infection. In most of the scenario and the severe neutropenia, not necessarily for every infection we need to remove it. So when we remove it, it is tunnel infection, a pocket infection in the chemoport, persistent fever or bacteremia, atypical infections or candidemia. Dr. Mallikarjun is going to discuss more in detail about it, so I'll not take longer time on, spend more time on that. Same thing for the mouth care, mucositis, severe mucositis, and our staff in the BMT and the oncology knows very well the approach what we follow. the primary thing is the oral cavity has to be relatively wet. It has to be moist, otherwise it becomes extremely painful to the patient. So we usually ask them to take liberal candies, make sure oral anesthetic gels are applied, oral anesthetic mouthwashes are being applied. At the same time, we cannot miss out on the infections. So sometimes herpes infections can be there. That can be the cause for these infections. Thrush, candidal infections, they can be one of the causes in the cases, particularly if they are not on prophylaxis. Rarely we need a biopsy to confirm whether it is part of graft versus host disease. So when do we add gram-positive therapy? If there is any hemodynamic instability, if pneumonia, positive cultures for gram-positives, if there is severe catheter-related infections, any localizing sign related to cellulitis or skin infection, colonization with any of these infections, and severe mucositis. What to do in penicillin allergy? We have fewer options. But these are the options we can choose amongst these antibiotics, including vancomycin, aztreonam, fluoroquinolones, if it has not been used as prophylaxis, or clindamycin. So antifungal we use quite a lot as prophylaxis in the patients who are likely to become neutropenic, and there is a one we need to look at whether there is a high risk or low risk. Same thing for antifungal, we look at the drug interaction and side effect profile whenever these antifungals are used, and we look for limited site of action depending on which particular group we need to target on. Some of the things related to what type of test to do, most of these tests have less relevance, so we have stopped doing most of these tests. We are going by exactly by the clinical scenario and the CT guidance. Prophylaxis we use mainly in the form of voriconazole or posaconazole during the transplant or AML therapy. Antiviral drugs, there is no indication for empirical use except when there is a transplant scenario, so we will not discuss too much in detail. The duration we usually follow for 7 to 14 days, and depending on the type of infection. If it is a fungal infection, the duration of therapy definitely goes much longer, depending on the type of mold or type of yeast that we have identified. Just a word about vaccination. Some of the part of the vaccination is live vaccines, high risk patient associated comorbidities, older age, previous history of neutropenia, poor nutrition, all these are the factors. Invariably, most of our cases will be on GCSF because only in solid tumors we may not use for certain type of therapies. In hematological malignancies, we end up using except in few other rare conditions. So this is just to sum up, how do we manage these cases. Fever, we decide in the low risk or high risk, decide for outpatient treatment or inpatient treatment. If the responding criteria is met, we may discontinue, or we decide for admission of the patient directly based on the progression. After 2 to 4 days of therapy, we decide whether the patient is responding, not responding, low risk, culture negative, we may decide to discharge on the oral antibiotics. If it is persistently culture negative, we may keep escalating the antibiotics, modify. If there is a documented infection, we modify according to the type of culture site, change the antibiotics. Then if the patient still is not responding or there is hemodynamic instability, we may go to this level of starting with a CT scan, doing a BAL test, or changing the antibiotic sensitivity, extending the antibiotic sensitivity further. So this is just a summary of what antibiotics we use in what particular scenario that we just discussed in terms of different antibiotics that are available and different antibiotics that we commonly use in our setup. So to sum up what we discussed, risk stratification of febrile neutropenia, early diagnosis, prompt initiation of therapy is important. Local microbiological epidemiology guides us what antibiotics to use, and response assessment decides for length of duration of the antibiotics. There is considerable morbidity and mortality with febrile neutropenia. Patients can be effectively prevented by use of growth factors, and they can be triaged based on what is the risk scoring we use. We need to make sure the patients are closely monitored. We need to make sure that the patient has to be seen very often, vitals to be monitored more closely. It is an oncological emergency, so we have to act really fast. Patients must be individualized. Risk for febrile neutropenia must be calculated for all. And universal precautions must apply, the same that we keep telling for most of these patients. I'll just put a word about transplant program, just few slides related to that. We have completed more than 350 transplants till now over last 15 years. We started in 2004, both related, unrelated, and haploidentical, and it is thanks to the staff here, their sincerity, dedication, that we have been able to achieve such a kind of milestone. We do a lot of haploidentical transplant. We are one of the first few centers in the country that has started doing a haploidentical transplant. Practically now, every patient has got a donor. Anybody with a sibling or even the cousin can be a donor. Less expensive. This has been just a flow chart of the type of transplants we have been doing. These are the various diseases we have done transplant. The host of it from more than 30 countries that we have done transplant to, for more than patients coming from more than 25 countries, we have done the transplants. The autologous transplants and allogenic transplant, they encompass nearly every possible conditions that we can think of in those who are curable by the transplants. We are recognized by one of the most prominent transplant group in the country and abroad. We are part of the registration of International Donor Registry and one of the major centers for transplant here. And as I said, this is entirely thanks to our nursing team. We wish the conference all the best, and thanks for all your effort.
Thank you so much, sir. It was indeed a thought-provoking session. Now may I request Ms. Arulbula Jasmine, Deputy Nursing Superintendent, to felicitate Dr. Ashish Dishit with the memento.
Before starting the next session, I would like to call Dr. Mallikarjun. May I request Sister Eunice Beulah to welcome Dr. Mallikarjun with a bouquet. May I invite our beloved Dr. Mallikarjun to share his knowledge on hand hygiene and care of lines.
Morning, everyone. Now that I've got my bouquet, I think I'm going to run away now. so I have no slides made, and this is a group discussion, right, sister? So they told me I have to just stand here and you guys will have to discuss among yourselves. No, it's not a joke, really. She's been after me to send slides, and I've sent a slide without my title, is it not? Yes. All of these are stolen for Google, okay? All right, so I think Dr. Ashish has covered most of my topic. In fact, the bouquet should also be given to him. All right, so anyone can volunteer. What are we going to talk? I'm sure all of you do it day in and day out. The question is not the knowledge of it. The question is doing it mindfully, is it not? So I'm sure most of people who work with us in oncology, bone marrow transplantation, neutropenia care, mucositis care would understand how important the very small steps that we talk about. Forget the guidelines, forget the scoring systems, forget the doctors, forget everything. If there is one thing that you would want to go back with, after all the hard work your organizing team and the leadership has put in here, that should be with your own clean hands, is it not? There is no intervention which is proved to be of greater value than hand hygiene. Nothing at all. It's such a simple thing, and we talk about it all the time, and yet, I'm sure, so we can all sit here and pat on each of our backs. I say good things about you, you say good things about me, and everybody is happy, go back home. But the truth is, I think last few weeks, 2 months, we have had more catheter-related infection. Now, why people said prevention is better than cure? We all knew it, is it not? From the day we enrolled ourselves into taking care of patients, we knew prevention is better than cure. And why is it more important in the group of patients that we care for? These are patients of cancer, hematological malignancy, solid organ tumors, and every cancer inherently is what? Is an immune compromised condition, right? Now, the infection can be because of a bug from outside, external source. Infection can be because of a bug which is inside, internal bug. And all of these are kept at bay because of our immune system, immune surveillance. What are the components of immune system? Anybody? I think we'll go with the boys, no? Boys are supposed to be. So everybody said the theme of dressing is purple and black. I wore a old purple shirt. There are boys with civil dresses there. Huh? The theme is not for them. Okay, so you know the immune system, right? There's an innate immune system, there is an adaptive immune system. So we talk about neutrophils, we talk about T cells, we talk about mucosal barriers. So all of these are at the forefront of protecting us from invasion of outside bugs, from the reactivation of bugs which are inside us, right? Now what happens in cancer is the whole immune system is compromised. It could be because of a lack of adaptive immune system. It could be because of breach of the mucosal barrier. It could be because of severe neutropenia, or it could just be because of the nature of the cancer, which makes the immune system go weak on its knees. When such a thing happens, either because of mucositis, either because of severe neutropenia, chemotherapy related, either because of breach of the barrier, because of an indwelling catheter, what happens is the host becomes really susceptible for these infections. And you know, in bone marrow transplantation, or a case of acute myeloid leukemia who's received 7+3 induction, they have neutropenia periods for a long time, right? 2 weeks of zero neutrophil count, 10 days of zero neutrophil count, 20 days of neutrophil count less than 100. And such patients, either have a gram-negative bacilli, and you know what happens, right? You give them all the antibiotics you want, you change the line, you do the antibiotic lock, but at the end of the day, it becomes extremely difficult to save them. You pour in all the antimicrobials that you want to, but once the infection becomes critically bad, there is no going back. The only way to save these patients is by doing everything we can to prevent from such an event happening. And believe me, one of the only proven ways to do that is hand wash. And I'm sure all of you know it better than I am. I'm sure all of you know the importance of it. And you know, certainly most of the places that our nurses work, there is enough access to do that. Oftentimes, knowing things in theory and being mindful about it, not just one day, not just 2 days, not just for one moment, but for every time, before entering the room, before touching a patient, after touching a line, after seeing a patient, is extremely important. And I can't overstate how important it is to prevent an infection, because when we lose a patient, we lose the mindfulness of why it happened, right? So I think, I'm going to go through the slides anyway, but there is no other message which is more important than the one that we have already discussed. So all of you, do you really do hand hygiene all the time? Yes. Really? Yes. All right. So even if those of you who are not saying yes behind the masks, you must start doing it. Yeah? So, and it is not just, when I say you, I'm talking about all of us, right? So certainly we think it's not such an important. So I was in a place called Vancouver General. There every year, so there would be surveillance cameras, of course. I don't know if we have them. So they would look at each unit, the critical care unit, the oncology unit, the surgical unit, and then they would actually rate the hand hygiene. The best hand hygiene unit would get award, because obviously they means they are the ones who are saving the patient. So I think one of the things that we all should do is kind of have surveillance, and then that certainly would increase the percentage of people practicing hand hygiene. And hand hygiene is not just, you know, washing hands for tokenism, is it not? We need to do it. We need to do it properly, and that is the only way to save people. Okay, let's run through the slides before they throw stones at me now. So we all think that we do the hand hygiene, but in reality, certainly doing it properly is not very high. And there are multiple studies, even in the most evolved countries and systems, that less than half people actually practice how it needs to be practiced. So, you know, what is hand hygiene? All of you know, it could be done by just soap and water, or it could be based on alcohol-based hand rub, to remove the germs. And it is really important that everybody who's involved in patient care must be doing it all the time. And it has to be done before you touch the patient. It has to be done before you enter the patient care system. It has to be done as any other person who's involved in any way in taking care of the patient, right? So it is the most important way to prevent the spread of germs. It helps to keep not just the patient healthy, but also you and your family members, because then you're not getting the bugs from the patient to yourself and to your family members. So even if you want to look after yourself, hand hygiene is extremely important. So using appropriate hand hygiene prevents contamination of the patient's, clients, or the residents' environment, which is very, very important. So when do you do it? Before the initial contact, before any procedure, after you're exposed to any body fluid, or after you have come in contact with patient. So hand hygiene prevents carrying germs in and out of patient's environment. That is important. So this just tell you the same thing over and over again, and that is the importance of doing it every day and every time you look after a patient. So clean your hands when leaving after touching any object or furniture also. So frequent contact surfaces are important source of catching an infection and then giving to other people. So the 4 moments of hand hygiene: before initial patient or patient environment contact, before any procedure, after exposure to any body fluid, and after contact with the patient or patient's environment. So it is important that we do that. So proper technique is also extremely important. And without proper hand hygiene, we know we can spread bugs with our hand. And that is the reason why. So when you use alcohol-based hand rub, so remember that you can't do it if your hands are soiled, of course. So when you do that, you apply enough of the product, rub your hands, and then make sure all your components of the hand are used. Most important thing is you don't use a towel or a tissue paper to wipe it off. You'll have to let it dry before performing any other task. That is important. So when you're using alcohol-based hand rub, do not dry it prematurely, and you know which one to use. And when you use soap and water, again, all of our places, they have actually put up the cartoons of how well to do the hand hygiene. So it is not for the lack of information really that people don't do it. It is just being mindful about the importance of doing it. And when you do it, how to do it properly is extremely important. Yeah. So I'm not going to read all of those lines because I'm sure that's going to bore you, but just make sure that you use a proper technique. So again, so there are various guidelines. I'm sure some girls may not like it. People say don't grow your nails, don't put nail color and all of that. But just be mindful that the patients that you are looking at or taking care of are extremely ill patients, and a few steps that you follow can be of great importance in deciding whether they live or we lose them. Okay? About central venous catheter again. So catheter-related infections are the commonest cause of mortality and morbidity, certainly in patients who have had allogenic transplantation, who have had myeloablative conditioning regimens. So again, these are the history and other things that you do not know. So various types. The ones that we use at our center are commonly PICC lines and ports. We don't use Hickmans as often in our center. So Swan-Ganz catheter is only for patients who are using pulmonary artery catheter pressure. So PICC lines are the ones which are commonest ones. And I think, again, PICC lines, 2 most common things why the lines come out in our center is one, PICC-related infection and PICC thrombosis. And both of those can be avoided or at least prevented in majority of the cases by the nursing care. So PICC-related infections and PICC-related thrombosis can easily be prevented most of the times by using proper measures. We call that catheter bundles. And most important thing again of this catheter bundle is indeed hand washing, barrier precautions, skin disinfection, avoidance of femoral. We don't use femoral catheter at all. And every day that we have a patient with a catheter, when we do our rounds, both nurses and doctors be mindful, do we need this catheter? And if the answer to that question is no, we must pull that line out as soon and as early as we can. Because once a catheter stays longer than it is useful, then we know that the risk becomes more and more for infection. So I think I'm going to leave a lot of time for breakfast, is it not? So few things again to drive. Hand hygiene is extremely important. Hand hygiene is extremely simple. Hand hygiene is easily doable. And hand hygiene is only one measure which is actually proven in multiple trials across the countries, across centers, to prevent infection, to reduce mortality and morbidity. And hand hygiene does not need complicated science. Yeah? Hand hygiene is not only important for patient care. Hand hygiene is not only important for preventing infection in a patient care. Hand hygiene not only saves lives of patients, but also of all of you Oftentimes I see nurses don't really value their own health and the family's health. So I see people touching blood and body fluids without gloves, either in hurry or because of compassion. It is extremely important that you take care of yourselves. Unless you are fit, unless you are strong, unless you are in a good space, you won't be able to do any good to others, right? So thank you all for having me, the organizing team. Hopefully all of you, when you go back, you'll go back with clean hands. Yeah? Thank you. Thank you.
I request Sister Shanta, Deputy Nursing Superintendent, to honor Dr. Mallikarjun with a memento.
We have representatives from WeCan. WeCan has been always a constant support to us, and they had sponsored for the program. I would request Sweta to hand over a bouquet to Ms. Salil Jayan from WeCan. Now we'll disperse for a short tea break. We'll adjourn within 15 minutes. So refreshments are arranged at the outside. Volunteers, please, guide the delegates to the refreshment area, and you are requested to be back within 15 minutes. Thank you.
ഡോക്ടർ അമിതിനെ എന്നെ വിളിച്ചേക്കണം. അതിനെന്തൊക്കെ കേട്ടോ? ഡോക്ടർ അമിത് വരാമെന്ന് പറഞ്ഞില്ല. ഇപ്പം അതെ സാധനം അപ്ഡേറ്റ് ആവുന്നില്ലല്ലോ. എന്നാൽ ശ്രദ്ധയോട് പറഞ്ഞിട്ടില്ലല്ലോ. റുക്കോ ഈ സാധനം അപ്ഡേറ്റ് ആവുന്നില്ലല്ലോ. ഈ ഡോക്ടർ രോഹിത് സെൻഡ് മെയിൽ. ഞാൻ വരാം, അവിടെ ഉണ്ടായിരുന്നു, ഞാൻ നോക്കട്ടെ. ഇത് അപ്ഡേറ്റ് ആവുന്നില്ലേ?
Request all the delegates to assemble back in the auditorium for the upcoming sessions.
നോട്ടാണ് ലെറ്റർ. അതന്നെ പറഞ്ഞത് ജിമെയിൽ ഓപ്പൺ ആവില്ല, അല്ലെങ്കിൽ എൻ്റെ ജിമെയിൽ ഓപ്പൺ ചെയ്താൽ അത് അപ്ഡേറ്റ് ആയി. ഹലോ, വാട്ട് ഹാപ്പൻ? Amit sir is coming. Okay, okay, thanks. Amit sir is coming. I will ask him. അല്ലെങ്കിൽ സ്റ്റാഫുകളോട് പറയണ്ട, സ്റ്റാഫുകളോട് പറയണ്ട. അത് വന്നു പറഞ്ഞത് ഹാനോടാണ് പറയാം. ഹാനോട് പറയാം. അവരുടെ പേരുണ്ടായിരുന്നു, ഞാനപ്പോൾ നോക്കിയപ്പോൾ ആളെ കണ്ടു. പുള്ളിക്കാർ കണ്ടപ്പോൾ
We shall restart the sessions. Kind attention, please. We are restarting the session. I request Ms. Gloria to welcome Dr. Amit Rohan with the bouquet. May I request the well-distinguished and beloved Dr. Amit Rohan, HOD and Consultant Medical Oncology, to share his excellency on pain management in oncology.
No, thank you. Good morning, everyone. I thank the organizing committee for having me here. It's been some years since I've seen a crowd of people sitting, and it's looking different. It's been almost 2 years since we've had a physical meeting, and probably this is the first physical meeting we are having in oncology, and it's the nursing oncology meeting. So it's very nice to see this. So anyway, thank you for having me. So what we'll do is, I think, is this visible? So what my topic is going to be is, I'm going to talk of management of cancer pain. And this is one of the most difficult things to treat in cancer. It's one of the most common complaint of every cancer patient. Anyone who comes with cancer, that's their first question which always comes, will I have pain? And will it be very painful for me? Will my journey be very painful? Will my end be very painful? And that's the most traumatic thing to listen to. And it's very difficult to manage. But this is something that all of us in oncology slowly start learning how to kind of adapt to answering these questions and how to manage this pain. And the first thing I think is learning the language. I think I have my nursing physician assistants who keep teaching me Kannada also, and we keep asking, the first thing in pain is if you don't know the language, you can't communicate your pain. So we do talk to patients saying, are you having pain when they come to us? We ask in Hindi saying, dard ho raha hai. We ask, nau ide, neppi ide. We go on in all languages trying to get the information out that are they suffering pain. And this is one area where everyone should be informed and everyone should be integrated in learning and managing it. It's not only the doctor who can do it, it's nurses who can do it, and anyone who communicates with the patient, anyone who gets in touch with the patient can actually help in pain management. Because just the way by which they talk to patients and they communicate with patients can help in relieving cancer pain. So this is an official definition of what is pain. Pain is an unpleasant sensory and emotional experience which is associated with an actual or a potential tissue damage. Now that is if there is tissue damage. But it can actually be something which resembles tissue damage, and that can also be an experience which is defined as pain. But for us, we look at it in a different way. We say, why do cancer patients have pain? And cancer patients can have pain due to many reasons. So the first main thing is the cancer itself. And it can be a cancer which grows bigger and bigger, presses onto tissues, and starts causing more and more pain. It can be a simple growth inside the soft tissue. It can be a growth externally. It can be a mass pressing onto the organ. It can be a mass which is involving the bones. It can be something which is causing a fracture of the bone. All of these can cause pain. Now, essentially, I always say, don't think cancer and pain are associated. Early stage cancer doesn't cause pain. And many patients will not come because saying, we didn't have pain, so we didn't have cancer. So we thought we didn't have cancer. Early stage cancer usually does not have pain. When pain starts, we kind of believe cancer has probably become a little advanced. It is causing pressure symptoms, and that's why the pain is happening. So if I see an early breast mass, it will be absolutely painless. If I see a mass in the abdomen, it may be entirely painless because there's so much space for it to grow. But yes, when it grows to a certain stage, it starts pressing on the nerves, pressing on the tissues, that's when pain starts. Or if it presses on the bone, pain starts. So in advanced cancer, it is universally common to have pain. And about 80% of patients with advanced cancer will have some pain or the other, and sometimes it can be very excruciating pain. These malignancy-related causes which we have listed out are one of those which really causes excruciating pain. It may be bone metastasis, it may be soft tissue metastasis, visceral metastasis, spread to brain, leptomeningeal spread, it can be spinal cord compression, it can be a pathological fracture. All of these can cause excruciating pain for patients. Now, this is due to the cancer itself. But before they come to us, they always have already having some hesitation, and they always ask, is it going to be painful even to diagnose it? And many patients will not want to do testing because they are scared of it. And that itself can also be painful. So pain for cancer patients can be the pain of investigation to get to know cancer. So they may come with some abnormality. We have to tell them we have to do a bone marrow because we are suspecting leukemia. The first question will be, how painful is the test? And bone marrow test, all of us know there is definitely some pain involved in the test. We do give local anesthesia, we get the pain down, but bone marrow testing is painful. So eventually, that is also a form of pain which can happen to patients. When we tell them we have to do a biopsy to diagnose cancer, the biopsy also can cause pain. So these are also pain associated with testing for the cancer. The other pain they can face is pain due to the treatment of cancer. And that is another issue with most patients. So they always will come with a misconception and say, I heard if you are going to give me chemotherapy, I will not take it because I've heard chemotherapy is very painful and I'd rather die of cancer. And this is a misconception in many people's mind because they believe chemotherapy is very painful. But this was because how chemo came in many years ago, the way it was given, the way the drugs were, now it has changed a lot. Now the way we do chemotherapy, earlier, even giving chemo IV is very painful. And that's why we say many of these drugs don't give IV. If you're choosing a drug, you choose the drug, don't give it intravenous via the IV line, put a chemo PICC line or put a chemo port. You'll give the chemo, extremely painless way of giving chemo. So that's why we insist in many cancers, don't start chemotherapy with an IV line. That is the most painful thing. And we say, you're giving pain. And patients will experience the pain. They will say, no, I will not come for future therapy. So we put a PICC line or we put a port. I think there are sessions in the afternoon about all this, which will be very interesting. There are ways by which you can give chemotherapy very painlessly, and you can reduce all your anxiety of patients. So that's one thing very important, putting PICC lines and ports. Secondly, chemo can also cause side effects. There is no doubt about it. Chemo can cause blisters, oral ulcers, and they can be very painful. So we have to tell our patients what chemo we are using, what to anticipate, but to understand that these will come and they will get healed, so don't worry about it. So treatment-related chemo-induced pain can be managed, and that is something that you have to prepare your patients for. Now, post-surgical pain, yes, obviously surgery is being done, post-surgical pain will happen, but that can be managed. These are all acute pains which go away. They are not chronic pains. So eventually, you have to counsel your patient that the pain which you are giving is very temporary so that you can cure the cancer. And that's why we say this part of pain also is a part of pain which the patient will suffer. And then there are other pains which happen because of comorbidities. In advanced cancer patients, they will become bedridden. And when they become bedridden, they will develop bed sores, and then pains may happen. They may develop constipation, which is not moving the bowels will also cause visceral pain to happen. So there are a lot of pain issues which happen due to the cancer treatment, and other things. And the last, and I think the most important pain which we kind of ignore, pain is also because of a manifestation of the fear of the patient. When you diagnose cancer and you tell them the first time they have cancer, they are scared. And that scare always comes into pain. And that scare is not only the scare for them, it is scare for them, it is scare for their family members, it is scare for the society, what will happen, it is scare for what their finances are going to happen, whether they can afford treatment. And all this leads to manifestations of pain. So this is another thing we have to understand. When cancer patients come, they have a lot of things happening in their minds, and one needs to really talk to them about all these issues. Basically, when we look at classically cancer pain, when we talk of the physical pain, we always talk it's divided into two types. We say nociceptive pain and neuropathic pain. Now, there are other pains, and when they all combine together, this slide really shows it is hell for the patient, and that's what happens. It becomes a very traumatic time for patients when all the pains combine together. When we say nociceptive pain, we are saying there is some tissue damage happening. Now that could be a somatic tissue or a visceral tissue. The somatic tissue means if there is some injury which is happening, some growth which is happening which is affecting the bone, it is causing a localized pain in that region, like a bone tumor. An osteosarcoma which is growing in the bone, that is causing a somatic pain. But if I have a tumor which is growing inside, suppose it's growing in the pancreas, it will cause a diffuse pain in the back. We won't know where it is happening from. It will cause a diffuse abdominal pain, and that is called as a visceral pain. There are other pains which are called neuropathic pains because of affection of the nerves, and that can be the central nervous system or the peripheral nervous system. So if I have a tumor which affects the brain and the spinal cord and causes pressure, it may cause headache, and those can be central nervous system pains. Affecting tumors which affect somewhere, there may be a growth in the lung which is pressing on the brachial plexus, and because of that they're having radicular pain in the hands. These are neuropathic pains which can happen. But again, one needs to understand there is also neuropathic pains which happen due to treatment. One of the commonest pains we see in our practice is because of the drugs which we use. We use a drug called paclitaxel. It is a very good drug for cancer care, but it causes neuropathic pains to happen. Look at psychologically, how is the patient functioning after that, after your treatment? Is this affecting his daily life activities? You should see his effect. Effect means you're talking of his mood. Is his mood being affected by this pain and by the pain management? Is his mood good during his treatment? You should see whether there are adverse effects for the drugs which you're using for pain relief. And lastly, this is important in cancer pain management. It is not very important in other pain management sometimes. Aberrant behavior is because you use a lot of opioids. For pain relief in cancer, opioids form a very important part. They can sometimes cause addictions. And as patients take more and more narcotics, they may become addicted, and they will show features of addiction. So aberrant behavior may come because of that, and that's something also we should be aware about. So when we assess patients, we generally look at these 5 factors very quickly. We can't really sit in the OPDs and look at all these points, but we looked at these 5 factors very quickly so that we can decide how adequately have we treated our patients for pain relief. So pain assessment, the first main thing is detailed history of pain. This is what we commonly do. Ask them, where is it paining, how many days, how long, is it acute, is it chronic, is it localized, is it diffuse, is there any other effect involved, any other organ involved? And these are the questions we normally ask. The next important thing is intensity of pain, and I think in this, the nursing staff is much better than us because they are daily doing these pain charts, and we keep seeing that included in our daily files, and that's an excellent thing to do, and we are very happy. Our nursing staff really does this very well. They take every day, intensity of pain is put up in the scale there, and we can just see it when we come for rounds, what scale did the patient's intensity pain was. Now, different pain scales are used. You can use sometimes the visual analog scale where you just look at it in between 1 to 10, say it's mild, moderate, or severe. You can do a numeric scale where you put in the number. And patients who can't read, or if you're treating children, then you can do the face scale where you look at the facial expression and say, is it mild pain, no pain, or very severe distressing pain where they're crying and they're distressed. So one of the pain scales should always be used, and it's very important to chart this, because once you chart it, it's not for now. What happens for us is, when you treat a patient of cancer, they will come back after 1 cycle of chemo after 21 days. By that time, you would have forgotten most of the things. So if you have charted this, on day 1, you know the pain scale was 8 or 9. And then when they came back 21 days later, when you give them the face scale again, they will say it is 2, it is 3. You know your treatment has worked. So it is very important that we chart a pain intensity scale, and it's very good that we see that it's being done every day in our practice, and that's an excellent feature which we have in our in most hospitals, and in our hospital especially, which we have seen, and I'm very happy about that. It helps patients because of this information which we get. Second is, though pain scale is one part of it where you're taking intensity of pain, but that's not the only thing. So many institutes use these kind of charts where you not only chart pain scale in one chart, you put in everything else. You put in pain, you put in fatigue, you put nausea, you put depression, you put anxiety, you put any other feature, you put loss of appetite, and all of it is charted numerically, and you create a number. And this is the Edmonton symptom assessment score, which is used in many places. But again, this is something which can take a little bit of time, and this becomes a problem always in busy practices, and even the nurses are very busy, and that's why sometimes these kind of charts become very difficult. So at least we say pain intensity, yes, we should always scale. If we have the establishment to do these kind of charts, we should do that, because they will give you an overall picture. So moving on to the next step is, how are we going to treat our patients with pain? Now, there are two basic parts of treatment. It is pharmacological, where we are talking of using medications, and non-pharmacological. Now, in pharmacological, we always talk of the medicines we use. Non-pharmacological is something I would like to stress on. This is very important. This is something which is ignored. Again, giving medicines is easier, so we give medicines, but non-pharmacological is very important because you are looking at different aspects of pain. So one is the physical therapy. You could do some form of physical, even doing something like acupressure, acupuncture, that can help in pain relief. You can do sometimes TENS, you can do hot therapy, cool therapy. All these can help in some form of pain relief. You can do psychological approaches, and this is very important. Psychological approach, what we have seen is when patients have severe pain, you talk to them, you counsel them, you kind of communicate with them, and even with that, their pain intensity comes down. Of course, because a lot of this is anxiety, and as you talk to them, you counsel them, the anxiety comes down, and with that, the pain comes down. So psychological approaches are good, and that's why there are other centers who do hypnosis for pain relief, and they do meditation, which is again very good. We encourage our patients to do yoga. Yoga and meditation, deep breathing exercises itself helps in bringing pain down. So these are things which are very positive for our patients. The medical procedures are there. I will talk to you about it in the end. And of course, the pharmacological we'll go to next. So basic principles of pain management for a patient. One is we should use medicines which are preferably by mouth. There's really no point saying I gave an injection and his pain went down, because once he goes home, he will not be able to take the injection regularly. So if I give a 8 hours injection in the hospital, if I'm sending the patient home on that injection, there's no use of that. Eventually, they will not take it on time and the pain will always come back. So best is to titrate the dose and use it by mouth. Oral tablets are the best. It should be round the clock. It cannot be SOS. You have to give patients in cancer pain many a times round the clock, 8 hourly, 6 hourly, 4 hourly, depending on the medicine you use. It should be titrated according to the pain scale. So depending on the pain, you may have to go up or down, and the treatment should always be individualized. Some patients will have some side effects due to some medicines. You cannot say this is the best pain medicine for all my patients. It doesn't work that way. Some patients will prefer Tramadol, some will prefer morphine, some will prefer codeine. So you have to titrate the drug and the dose. These are the basic groups of drugs. We talk of non-opioids, opioids, and adjuvants. These are the three basic big group of drugs we talk about. In non-opioids, we are talking basically of paracetamol and NSAIDs. In opioids, we are talking of the various opioid groups. And adjuvants, we are talking of steroids, antidepressants, anticonvulsants, and bisphosphonates also play a role. Now, let me tell you quickly. So non-opioids, paracetamol is the basic dose, one of the best drugs for pain relief. After paracetamol, we use NSAIDs, and NSAIDs could be, we could use naproxen, we could use ibuprofen, but there is always a limitation to NSAID. NSAID has a ceiling effect. You can't keep increasing the dose and saying the pain relief will get better at higher dose. After a certain dose, there is no further pain relief. And second, after a dose, it will also have toxicity. So the problem with NSAIDs is it causes end organ damage, especially we talk about renal dysfunction, liver dysfunction, all that can happen if you keep increasing the dose. So we cannot, the disadvantage is we cannot keep increasing the dose. What is the advantage of NSAIDs? They have no addiction. So you really will not get addicted as you can get to an opioid drug. Opioids, we have multiple group of drugs. They are classified in multiple ways, but the most common classification we prefer for usage is whether it's a strong opioid, whether it's an intermediate opioid, or if it's a weak morphine, fentanyl. These are strong opioids. Intermediate opioids are something like buprenorphine, and weak opioids. Codeine is a weak opioid, and nowadays what we use most commonly, we use tramadol, Tramadol. That's a weak opioid, or we use tapentadol. That's Tidol, which we use. It's a weak opioid. Just a quick word on morphine. That's opioids sometimes are very scary for patients. Sometimes when you tell a patient we are putting on opioids, they refuse it, saying, oh, that means I'm probably terminal. That's why you're putting me on opioid. I'm going to die very soon. We try to explain to patients it is not about using it terminally. That was an old concept when we used to use morphine terminally. Nowadays, you always say you use an opioid to reduce the pain, get the patient back into a good quality of life, titrate the dose, and you can stop the dose. You don't have to really continue it if it's a pain. Use it oral, IV, sub-Q. It is one of the best opioid drugs. It is very, very powerful. That's one thing we have to be very careful about. Fentanyl is another drug. Why I mentioned is because this helps a lot of patients of our advanced cancers who go home and can't swallow. Suppose they have a cancer of the stomach, cancer of the intestine, and they cannot eat. So you will say, I put my patient on morphine and send them home with oral morphine. But they will not be able to swallow the morphine because the cancer growth is in the stomach or there is in the colon and they are obstructed. If there's obstruction, nothing is going to go down. or they have an oral throat cancer and the cancer has caused obstruction and they can't eat. So then oral drugs may not help there. And there, when you think I'll put my patient on IV and send them home, you can't do it. You can't give an injection at home which the patient will take indefinitely. So that's where subcutaneous patches of pain relief medicines are very important for us. And fentanyl patches are one of those. Fentanyl patches can be applied to the skin, and they are transdermal patches that the opioid gets absorbed. It works for 72 hours, and then after 72 hours, you remove the patch, then you put a new patch. And this way, you can get very good pain relief for patients who can't take oral tablets. But yes, it is something which will not work in acute pain because it takes time for the effect to come. So for acute pain, we still say use short-acting opioids, get the effect, and later put your patients on fentanyl. So these are some of the opioids which we use in clinical practice. Another important part is adjuvants in pain management. Now, adjuvants are drugs which you are using as accessories, which are helping in pain and which also are helping you think, oh, they are treating me because I have a psychological problem, I'm depressed. So they'll tell you immediately, no, I'm not depressed. Why are you giving me these antidepressants? I don't want them. So nowadays what happens is you make a prescription, the patient takes the prescription first thing and puts it in Google. And they get a full prescription chart of what each medicine is. That's the first thing which happens. I had a patient whom we gave a drug which is very, very effective, but she came back and she screamed at me, say, you thinking I'm a psychiatric patient? You did not, you were just, without telling me or giving me, and that's why communication is very important. So when we say we are giving a drug, we have to explain sometimes why are we doing it. So we had to sit with that lady, half an hour we spent with her saying, no, you have a typical neuropathic pain which does not get better even with NSAIDs and opioids. Neuropathic pains typically are very resistant to these kind of things. So you have to use an antidepressant drug or an anticonvulsant drug and the pain will come down immediately. So that's why for neuropathic drugs you use tryptomer, amitriptyline at a very small dose. In depression you sometimes have to give it a very high doses, but here you use very small doses. Similarly, anticonvulsants, gabapentin so commonly to our patients. Pregabalin is one of the common drugs used. Which is a monoclonal antibody, which actually remodels the bone and gives good pain relief for bone pains. So depending on the situation, we can use our drugs and we can manage patients. So how, I've told you the group of drugs, so how do we manage very quickly? We follow the WHO analgesic ladder. This was almost made about 30-40 years back, but it is still true for relevant for clinical usage even today. If your patient with cancer has mild pain, we say don't use an opioid. Start with a non-opioid drug first. If the pain increases, go to step 2. Step 2, use a low dose opioid. Don't use a high intensity opioid. Use a weak opioid, and you can add either an NSAID or you can add an adjuvant drug. And if the pain still doesn't get better, we say go up to step 3. And in step 3, always use a potent opioid. And with that, you combine an adjuvant drug and combine a NSAID also. So these are things which we do and manage pain. This is the recent it's not recent, it's many years back now. We used to use that WHO 3-step ladder. Now WHO has made it a 4-step ladder, which they say it's bidirectional. Earlier you used to say 3-step means you move from 1, 2, 3, but you don't go down. Here you say you move from 1, 2, and 3 are the same, but even then if your pain doesn't get better, think of doing some of these pain procedures, nerve blocks, you can do PCA pumps, you can neurolytic agents, and with this, by doing a procedure, you're going to step 4. But the thing is, if you get good pain relief after this, you can go downwards. So this is a bidirectional kind of a WHO ladder. Every drug has side effects. You cannot tell your patient that we'll give you opioid, your pain will go off, nothing will happen, don't worry, no side effects. Every drug has side effects. Opioids, we worry about constipation. We give them prescriptions of what to do when they take an opioid. Also start the Dufalac or some form of medicines to reduce the constipation. They can have nausea, vomiting. The opioids can make patients very sleepy. Sometimes they can be very drowsy, so you may have to reduce the dose. So these are things we should know when we use an opioid. Also, addiction with opioid is always a worry, and that is something we should always be careful about. NSAIDs also have side effects. You can't write ibuprofen for your patient indefinitely and say keep taking it. They will come with a peptic ulcer and a GI bleed, so we have to be very careful. They can have renal dysfunction. They can have sometimes low platelets and bleeding abnormalities, so we need to be careful about these. So in spite of all these, we sometimes don't get adequate pain relief. In spite of we know all these group of medicines, we have such a big group of medicines. We have opioids, non-opioids, adjuvants. we still don't have patients who, we'll have patients who will say they are not getting adequate pain relief, and this could be due to various reasons. The basic reason is always the lack of knowledge of the drug, and the lack of knowledge is not only on the side of the patient, it is also on the side of the treating physicians. We ourselves sometimes don't get equipped enough to manage pain better, and everyone has a hesitancy of using an opioid, saying, oh, it is over addictive, we should not use it. Sometimes that may be the problem. Sometimes we give very low doses thinking, oh, this should be enough for pain relief. Eventually, there are different reasons, but one needs to always look at our patient, understand what their intensity of pain is, what all factors are involved, and then get the right dose for pain relief. So awareness is very important, awareness for the physician, awareness for the patient, awareness for the nursing staff who is taking care of the patient. Everyone should be aware of everything of the drugs which we are giving, how they are being given, why they are giving, side effects, and that way we can manage pain better. Lastly, I told you procedures for pain relief has now caught on. That's the WHO ladder step 4 which has come in, and this is now becoming a prominent measure for pain relief. You can do sometimes patients who have visceral pain due to pancreatic masses, due to visceral growths, which we can't control by any medicine. You can do what is called a celiac plexus block. You do a procedure where you block the celiac ganglion, and with that the pain comes down. You can do epidural infusions. They put an epidural catheter, and with that they give analgesics, opioids, and that can help in pain relief. Vertebroplasty is a procedure which we do a lot in our center. Our orthosurgeons do it extensively. When you have compression fractures or bone fractures, they go in there, they take a biopsy, and they put in bone cement. And what happens with that is there's destruction of the nerves there, and the bone stabilizes also, and the pain also comes down. So vertebroplasty in our institute is a very, very procedure being done a lot for pain relief for our cancer patients. And then there are these newer things like intrathecal pumps, which again we don't do too commonly, but they are used in rare situations. So this is my last slide. One needs to understand cancer patients have multifactorial nature of pain. Never think pain is only due to the cancer growth. My thought would be, one can always blame the cancer for everything. You know, you say the cancer is growing and it's causing all the problems, but the pain will be multifactorial. It can be a somatic or a nociceptive pain or a visceral pain, but there are a lot of other reasons for pain. There are neuropathic mechanisms which are happening for pain. There are psychological reasons for pain. There are a lot of psychosocial influences for pain. There is always the fear of cancer, the fear of death in patients. There's financial reasons. There's always that thought in the mind, how am I going to take this treatment? And all of these add on and cause pain for our patients. Eventually, it is a lot of spending time with patients, trying to talk to them, trying to understand what their situation is. And I always tell everyone, we as physicians try to spend time in our ways, but I always tell everyone should spend time with them, and that's what we encourage everyone to do. The nurses, you are coming in contact much longer with patients when they are inpatients. We see patients much more when they are outpatients. You should spend time with them, talk to them, understand what their problems are. We tell our physician assistant, they spend time to them. There are a lot of things they don't tell us, but they tell them. And with these kind of things, when we integrate all of this together, we can give best pain relief for our patients, and we can give patients a good quality of life. Eventually, there are a lot of cancers which you can't cure when you see them in stage 4. We always tell, a cure may not be possible, but you can at least give them a good quality of life. You can keep their suffering down at least for whatever time they have. They should not suffer too much. Thank you, everyone. Thank you very much.
Thank you so much for the valuable session, sir. May I request Sister Maggie to come forward and honor Dr. Amit with the memento. I'd like to invite Sister Arulbiola Jasmine to welcome Dr. Vadiraj with the floral bouquet. May I invite the very renowned Dr. Vadiraj, consultant radiation oncology, to share his excellency on care of patient on radiation therapy.
Good afternoon, all of you. Has anyone worked in radiotherapy department here? So I think this presentation may be useful because I always have difficulty when I ask for a replacement when our regular sister goes on leave. Usually they think sisters do not have or nurses do not have any work in radiotherapy department. That's because doctors take care of the patients and technology treats. What will the sisters do? The second problem is when somebody is sent for replacement, they are always in a fear when they come to our department of radiation oncology. They get exposed to radiation. So this is the safest department because when the department is built, the safety is the first concern, and we take prior permissions from AERB. And if you look at our sister Elizabeth's record in the last 10 years, she has not even crossed the permissible limit for the general public. Leave about the healthcare worker. So it is that safe compared to orthopedics department or cardiology or radiology department. So the safety is quite okay. That's not a problem. So I straight away go to the responsibilities of a nurse or a sister. I have kept this in mind, sisters aspects, not the doctors or the technologists. Basically, they are involved in initial assessments. So it depends on how much they get involved, because if suppose somebody is posted and they are just 6 months, probably they wouldn't pick up anything. They wouldn't know what the process is. Basically, if they have worked for more than a couple of years, then I think they are comfortable explaining the patients regarding the process of radiation treatment. This talk is basically telling the same thing, how we take a patient through the radiation treatment process and how the nurses get involved. They monitor these vital signs and symptoms. Basically, weight monitoring is pretty important in oncology department because these patients, either they have head and neck cancer or esophageal or the abdominal or pelvic malignancy, where radiation causes side effects like loss of taste, thick saliva, and various other problems, which I'll be mentioning in next few slides. So they're bound to have weight loss. That's why it becomes important to monitor the weight every week. We may not be able to ask the patients every week, what is your weight? Sometimes sisters have to meticulously document this on the radiation chart throughout the treatment, as well as they also get attached to these patients during follow-up, because we call all these patients once in 3 months for follow-up. And they also become a part of routine examinations. We see maximum number of head and neck, breast, and gynecologic malignancies. And sometimes we may have to do the biopsies, and during the radiation treatment we have to assess the reactions. So sometimes if nurses get involved, probably they also can see the grade of reaction and bring it to the notice of the treating technologists or the doctors. So what do we do after we examine the patients? We have to get these patients' treatment started. So it all starts with acquiring a CT scan. And we have a dedicated big bore CT simulator, which is 16 slice, and sisters have to position the patient here, make the patient comfortable, explain them this is the process of treatment. Sometimes catheterization is required, IV line has to be secured, and contrast administration. They also learn a bit of handling this equipment, especially the injector. And they also should be familiar with the side effects of radiation treatment before we start the patients on treatment, because generally the patients discuss about the treatment aspect with the doctors and how long it will take and so on, but they may be hesitant to ask all the side effects, and sometimes we also may not spend that much time with the patient. So generally they are more comfortable and they get more attached with the sisters, and then probably they are the ones who can communicate all these things and make the patient comfortable. And These patients also have various other side effects. I have mentioned just nausea, vomiting and dehydration. Sometimes we may have to give some injections and IV fluids and supportive management. So they have a lot of work. The nurses or sisters, they have a lot of work. And here you can see this patient, sometimes we may have to do the active breath coordination for the left side breast cancer. So certain positioning and other things are required. So they get involved with these procedures along with the technologists and the doctors. And once the scanning is done, we mark out the area which needs to be treated, and then we give an appointment to the patient, and then we take up these patients for the treatment. We have two machines. One is Electa Infinity and the other one is Radixact 9. So it's pretty busy, and we have two sisters. Probably sometimes they have to handle brachytherapy also. It becomes too tight because sometimes the patients can do the gargle with benzidamine or plain water and keep swishing the mouth so that the mouth doesn't get dry because the parotid glands gets exposed to radiation. Or they can tell the patients that they can take 100 ml of water, put 1 spoon of baking soda and a half spoon of salt, and then gargle as frequently as possible so that the food particles does not stay in the oral cavity. These are simple measures, and sometimes we think, do we have to tell even this? So, but it matters to the patient, because if they are not told, they don't know what it is. And dry mouth, difficulty in swallowing, change in taste, or nausea, all these symptoms can happen. Either they might advise the common remedies or they might bring it to the notice of the treating doctor. Loss of taste is a phenomenon which we cannot treat, but taste buds are more sensitive for radiation, but slowly it improves. But one thing we have to emphasize is that even though there is a loss of taste, they have to take adequate food. If they are not able to take food adequately, probably they have to take frequent liquids or semi-solids, whatever they can. But reduction in the food intake will also reduce in weight, and they are not able to tolerate the treatment. Swelling and skin texture might change, or skin irritation, dryness or dry desquamation or peeling can happen. So sometimes these sisters, they can tell them that they should not rub the treated area, and they should not apply any lotion or cream on the treated area because the skin might peel off. Once the skin peels off, then the healing takes a long time. These simple things, probably the nurse or the sister, they can tell in the department. They can tell that not to scratch the treated area, avoid rubbing, and after taking bath, gently dab that area. And sometimes jaws may become stiff, especially when we treat the head and neck region, and we have to train them to use either, earlier we used to tell them to use a couple of ice cream sticks and keep in between the teeth and gradually increase that so that their mouth opening increases. But these days we have Hester's mouth screw, and all these things probably the nurses can get involved, or the sisters, because all these things, one person to tell the patient, I think it becomes quite difficult. Sometimes if they are not able to, if the nurses, they are not able to counsel the patient regarding the food intake or making it semi-solid, or some nutritional advice, especially egg white, those who can take eggs, because protein requirement is high. So these patients may be directed to the nutrition department for further advice. And these are some of the side effects we generally notice in the head and neck region. The mucositis, either just a redness grade 1 or ulceration grade 3, or sometimes the skin reaction. People may require either Ryle's tube or sometimes a PEG tube feeding. So generally we put the Ryle's tube, or sometimes we send to gastroenterology department for PEG tube insertion. So the doctors, they will insert the PEG tube. After that, patient will be wondering how to feed or how to take care of that, because many even don't know what syringe has to be used, how to couple the syringe with the PEG tube, how much feeding has to be done, whether it has to be given in the supine position or patient has to sit. Because if the patient is made to lie down and then we give PEG feed, immediately it goes through the esophagus, and then probably they may aspirate if they are not conscious enough. So all these things needs to be taught. But to teach this from the nurse point of view, they have to be in the department. They should have seen all these things over many years. So then only they will be able to tell the patients. Weight monitoring I already mentioned, and dryness of mouth. And if there is dryness of mouth, they can tell either the patients can take non-sugary gum or maybe frequent sips of water or fluids, that would help. So all these things I mentioned regarding the care of the teeth, gums, mouth and throat. Avoid spices and coarse foods such as raw vegetables, peppered, because there will be ulcers. They cannot eat hard food, nuts. Do not eat or drink very hot foods, and do not smoke, chew tobacco, drink alcohol, because tobacco and alcohol can further. We emphasize this during the counseling before we take up the patient for treatment, but sometimes if it is not repeatedly told, the patients will forget and they again get back to the same. And sipping frequent either sips of water or drinks, I think that is advised. And moisten the food and gravies and sauce to make eating easier. We should whatever knowledge we have in telling the patient to consume the food in an easy way, I think we have to inform them. And oral hygiene, as I mentioned, 1 glass of water, spoon of soda bicarb and half spoon of salt, which will remove the debris and prevent irritation and promotes healing. And nutritional advice, I think I already mentioned that. Drink milkshakes or prepared liquids, frequent liquid or semi-solid. If they are able to take solid, it is good. Even though the patient has pain while swallowing, especially we treat the head and neck area, we have to tell them how much ever difficulty is there, you still try to take, because what happens, if suppose 1.5 months of radiation treatment for the oropharyngeal area and another 1.5 months of recovery, we put PEG tube and we put Ryle's tube, we still tell the patients whatever is possible, please take. That is because the constrictor muscles, it gets atrophied, it becomes useless. The mechanisms, swallowing mechanisms become rudimentary. I have seen one patient, I have treated this postcricoid region which is very sensitive for radiation. Now 7 years down the line, the patient was put on PEG tube before the start of radiation treatment. Even after 7 years, she hesitates to take through orally. The endoscopy, almost all hospitals in Bangalore, they have done the scopy and they have told the lumen is patent, but the patient's fear in mind that she cannot swallow, she gets choking. So we have to encourage these patients to take as much as possible, even if they have pain, even if there is Ryle's tube or PEG tube. These are basically to top up. If the intake comes down, probably this can be used. But the main natural mechanism has to be kept intact, and we have to keep on telling them every day it has to be used. Okay? And supportive care, if at all fever, nausea, vomiting or any other symptoms, the regular things can be advised. Ryle's tube and percutaneous endoscopic gastrotomy care, and sometimes these patients have large ulcerated wound in whichever area of the body to be treated, and we may have to take out the dressing in the treatment room and then give the treatment and then again do the redressing. So usually the change of dressing will be done in the treatment room, or at least before going to the treatment room, and when they come back and again the dressing has to be done. If they are careful enough, they can observe all these grade 1 to 3, either the skin or mucosal reaction, and they themselves can advise, or they can bring it to the notice of the treating doctor. And some of these patients in head and neck cancer, they come with stridor because of the laryngeal malignancy, and every time we can't send these patients go to either surgical oncology or ENT. We have suction, and sometimes these patients require oxygen also because they have breathing difficulty, saturation comes down. All these things, I think we have to handle it in department. And they also coordinate with the brachytherapy activities, and we have a dedicated in -2 only a minor OTA, and we do the head and neck brachytherapy, and the cervix is the commonest one, soft tissue sarcoma, breast, which all these brachytherapy procedures we do. It's basically a OT procedure, and they have to prepare all the instruments for that, and then arrange the patient, and then coordinate with the anesthetist. And if the patients have pain, especially when we have put the implants, and they have to inform the anesthetist, constantly be in touch. It's a whole day procedure, morning till evening admission, and sometimes a patient will have pain. We have to get the patient controlled analgesia pump with the help of anesthetist. All these things needs to be monitored. And when we take up the patient for the radiation treatment, usually they are shifted to this protected room, wherein the treating staff would not get any dose, only the patient is kept inside. The patients usually have fear in their mind that they are alone in the department, in the room. So we have to assure them that somebody is constantly monitoring from outside, and sometimes there's a mic. We constantly speak to the patients, and this usually the treating nurse or will take care of this. And while on brachytherapy, they have to monitor several things, the vitals, look for any bleeding, especially we would have put needles, and sometimes they have bleeding, drop in BP, and fluid management, pain management, what Dr. Amitrautan mentioned. And these are some of the commonest brachytherapy procedures we do for the head and neck, and this is the CA esophagus, and then the carcinoma breast and cervix implants. Thank you. So I was asked to wind up with only 12 slides. So I think I have stuck to that. Thank you. Thanks a lot.
Thank you so much for a very informative session. Any questions from the audience? Any queries?
Yeah, basically, when the patient, we take the consent, as doctors, first we explain the entire procedure. So in my consultation room, I have, like I showed you all those slides, some patients are okay to listen to everything. Some patients say, no, I don't want to see all those things. I get fear in my mind. But it's my responsibility to tell them, this is the procedure. We first take the anesthesia clearance, and then the sisters will take you inside the room, induce, and after that these catheters are put. After that, once they come out, at the time of procedure they don't have pain, and once they come out, then after few hours, if it is spinal anesthesia, 3 hours later they'll start getting sensation and the pain will be there. We take help of anesthesia department, we try to reduce your pain. All those things we upfront tell them. And throughout the day, suppose we do the morning procedure for cervix cancer patients, throughout the day the nursing staff is available there. We have 2 beds. We don't do more than 2 procedures in a day because taking care of the patients will become difficult. So they are there constantly monitoring the patients, and that itself is a sort of psychological support. If they say pain, okay, we will inform the doctor, or it will be there, please bear it. So in some time the procedure gets over, we will remove it. That is the, I think, biggest support, and counseling again and again, and being there by the side of the patient. So they are always there, and whatever medically required, we do that. In between, if at all the patient has unbearable pain, they call us. Sometimes whatever injections or medicines we advise the sisters to give, if still the pain doesn't come down, we inform the morning anesthesia team, and they will come and they also take care. So basically it's the counseling plus constant care of the patient throughout the day. Thank you. Very good suggestion. I think I'll write to the management, because many people have told, no, it's a good suggestion, because recently we commissioned this Radixact 9. The treatment takes almost 15 minutes, and we had requested the management to put a music system. So obviously small things gets missed out. I think it's a very good suggestion. Yeah, thank you.
Thank you so much for addressing our queries, sir. May I request Ms. Judith Vasan to honor Dr. Vadiraj with the memento. Thank you, sir. Thank you, ma'am. Coming up, an upcoming session on an interesting topic by Dr. Poonam Patil on coping strategies for oncology patients. May I invite Dr. Poonam Patil to take the session.
Thank you very much for this invitation. And I must congratulate the nursing team for organizing such a wonderful sessions today. And very good. So today my topic actually is a little vague. Coping is not just for cancer, for everything, for every one of us in day-to-day life with so many scenarios. So here I'm going to talk in reference to cancer patients, but coping is something that we all have to go through in our life in various times, in various scenarios. And this is just a cartoon showing what coping actually does. It builds our confidence. It helps manage emotions better, improves our behavior, improves independence, improves self-regulation, helps manage stress, helps work through challenges. So this is a general thing that what coping does. We all know the meaning of coping in various ways that we have coped up with. But let's look at what is the actual definition that the dictionary says. So coping refers to the attitudes and behaviors that you use to maintain your emotional well-being and adjust to the stresses caused by cancer. This is in relation to oncology. So what is the key tag here? Emotional well-being. Because physical well-being is probably not in our control, but emotional well-being is definitely something that we all can work about in various scenarios. So there are many goals and challenges. Medical, what is the medical history, illness that we are going through. Physical, it may be a simple injury, a fracture which disables the person for months together, or even COVID, where the person was supposedly not having much symptoms, but earlier when the COVID was, the illness was diagnosed, people were confined to a room in the hospital for 1 month alone. And so that was also some coping mechanism that they had to go through. So physical coping, emotional coping, interpersonal relationships, when they go sour, then we cope up with it in various ways. Spiritual coping. So coping strategies are not applicable to all patients, and there is no one size that fits all. It's different for different people at different walks of life in different scenarios. So what strategies work best for one person may not work so well for another. And it's an evolving process. It's a process that goes on over months and years, and patients use different strategies at different times depending on the changing situation. And we always think that emotional aspect is something that we don't want to talk about, but you'll be surprised to know that there is so much research going on coping strategies used by large number of patients, and some strategies in general are better than others. So I'll be just talking or touching about these strategies and why the importance of coping in cancer patients in this conference, because it's not just the cancer patient with whom you are in contact with, but it's also the caregiver who needs some coping mechanisms to be taught. And not just the caregiver, that is the patient attender. Even you are also caregivers in this scenario. Even we are caregivers in this scenario. And even we require some coping. Even you require some coping. And I'll be touching about these mechanisms in this small talk. So we have to stress on strategies to reduce stress. And one person depends on the other. And coping is not just one person, it's always a human chain. And you have to move forward after cancer, during therapy or after therapy, and that is what is coping, which helps in moving a person forward. And nurses do make the difference. So some known strategies that are defined for coping with cancer. First is facing the reality of your illness. Now, you all must have seen in the wards and hospitals that patients' relatives tell that don't tell the relative that the patient has cancer, patient is very weak, he will not be able to take it, he may not agree for treatment if he comes to know that he has cancer. So they try to not tell the relative. But on the other hand, the relatives also are clever. They feel that the patient doesn't know, but patient already is knowing in his heart of hearts, and he doesn't want to tell to the relatives that I think I'm having cancer. So they're both hiding from each other. So coping doesn't help here because the channels of communication are not open. So to hide one lie, you have to tell another lie. So face the reality of your illness, accept the illness, do some research, ask questions to the treating physician, and denial is also a coping mechanism. So many times patients come to oncology, they say that I have been told that I have cancer, but I am doing very well, I have not lost weight, I don't have fever, I am eating very well, I go for 10 kilometers walk every day, I don't think I have cancer. So that is also a type of coping. Denial is also a type of coping because it is protecting that person from being overwhelmed. If suddenly the person comes to know that he has malignancy and he gets emotionally devastated, so this denial is probably the beginning of his coping. So it can prevent patients from coming to terms with their illnesses and getting on with other constructive ways of coping. But the good part is that it generally fades over time. And I'm sure Shraddha will be talking more about it later. And denial then gives rise to acceptance. Maintaining hope and optimism. Always when we talk to the patient, any patient for that matter, we'll always console the patient, oh, sad to know that you have this diagnosis, but let's face it, come on, let's do whatever we can to treat you. You will eventually get better. Even a person, you're shifting for OT, that person is always scared that what will happen to me. They feel that they're going to the operation theater, they'll be anesthetized and they may not ever come out again to see their loved ones back in the room. So you try to console the patients in your own ways, but that is what is there even in cancer patients, that you have to maintain hope and optimism because it's not wrong. There is hope and there is optimism in cancer as well. Patients hopeful and optimistic about the future course of events, they show better adjustment to their illness than patients who are pessimistic. Some studies have also shown that optimism is associated with better medical outcomes. Proportion and balance. It does not mean that if you are hopeful and optimistic, you should become totally careless and do whatever you want. There has to be a kind of balance. You should know that this particular illness, whether it is malignancy or COVID, even in COVID, initial part we knew. Why I'm referring to COVID? Because that is something that we have all seen in the recent past. Whereas, so it's kind of fresh in our minds. Whenever the word COVID infection used to come in our minds, almost 14, 15 months back, we all used to equate it with death. So that is what people also had this misconception with cancers. They used to equate it with death. But now we know that it's not true. Having said that, none of the illnesses have 100% cure rates. So you should know what are the correct statistics. You should know that COVID today is 99% of them are going to get cured. In fact, many people are going to be asymptomatic. Only 1% may require hospitalization. Even in that hospitalized patients, hardly within the hospitalized patient group, only 4 or 5 may eventually die. Now the Karnataka statistics are there may be 1 or 2 deaths in a day of lakhs of people who are getting affected. So patients who maintain this kind of mixed emotional response, that is, there is some pessimism, but there is optimism as well, and they are well proportioned to the realities of their illnesses, enjoy a better psychological adjustment than patients who feel too optimistic or too pessimistic. Expressing your emotions. People differ in the way they express and communicate how they feel. And in our society, women generally communicate better than men. How do they communicate? By crying. So it is something that is very natural and normal that we all cry so easily. But it is a way of penting up the emotions which have been pent up. It is kind of opening up for women, which they very easily do. And now there are so many ways of opening or expressing your emotions. You have seen the child life practitioners, they give some paper and a pen or crayons to the children. They will draw. If they are drawing a dragon, it means that the child is probably a little stressed, but if the child is drawing something very nice and very cute, we feel that, okay, the child is taking the illness very well. So that's how they are expressing their emotions. And even writing a diary is supposed to be very helpful in expressing emotions. So expressing emotions is not just talking to another person. It may be even writing down. It may be even picturizing yourself. It may be even writing or penning some poem. It may be drawing something. So there are various ways in expressing one's emotions. Reaching out for support. The patients who have loved ones available for close emotional support always are going to do well. And they call upon their support for practical help, and these patients show a better psychological adjustment to cancer than patients who are largely alone or tend to go it alone. Patients feel that this disease is for me. Why should I trouble my family? I will not tell my son, or I will not tell my wife, or I will not tell my parents that I am having pain. It is my illness. I will only suffer. But ultimately, that is not a good thing to do. So you must reach out for support. You might have read in papers about many film actors or people who are of high profile even committing suicide. So that also has been due to depression, due to various reasons. And always when such an incident happens, it will come out in papers for a few days that you should reach out for support, call, we are just a call away, but many times practically it does not happen. So if we find any patient who may be on the verge of getting depressed, we should be proactive and reach out for support to them. Adopting a participatory stance, that is strong fighting spirit, find ways of putting it into action, go out of their way to learn about their illness and the options for treatment. That means they are having active participation in their treatment plan. They pursue the best treatments available and also consider alternative or holistic approaches. You must have seen integrative cancer therapy is now something very well known, that it's not just the medications, but you should have a good family support, a good friend support, do good nutrition, have a healthy lifestyle, exercises, meditation. All these things are a part of coping, helping you to cope. So a lot depends on what I do and how I take part in my own activities. Finding a positive meaning. A patient should reflect on their values and priorities and often identify changes that are warranted and perhaps overdue in their lifestyles and personal relationships. This is often called the enlightenment or gift that comes with cancer or the wake-up call. Now again, with reference to COVID, people say that when we were inside the room for almost 2, 3, 4 weeks, we thought, oh, this is useless, that is useless, I did not talk to that friend, or I did not meet that friend, I must go and reach out. So many things came to their mind at that time. So when we feel that I may not live till tomorrow, then we realize all these things, oh, what all I could have done. So that is what is the meaning of this. This is often called the enlightenment. Patients who embrace this aspect of their cancer experiences have been found to be especially well adjusted and better able to deal with many of the trials and disruptions caused by their illnesses. Spirituality, faith, and prayer, they are not religion. It is different than religion. And these are fundamental beliefs, and these beliefs can be called upon for help in dealing with cancer. They benefit in a variety of ways. They have a greater sense of peace, an inner strength, an ability to cope, and show an improved psychological adjustment and quality of life. So this does not mean I may be from any religion, but spirituality, faith, and prayer are totally different. Maintaining self-esteem. Cancer patients often tend to hide themselves. Many of the patients have told that I have not told my friends that I am having cancer, I am having hair fall, so I am not meeting these people, I am not going to office. So this is a stigma of having cancer. It can imply something bad about the person who has it, but we all know that cancer is not a disease which the person had invited. It happened. It can happen to anybody, including us. So there should not be any stigma, and we should always reach out and comfort the patient. In addition, many of the sources of self-esteem can be threatened by cancer and the effects of medical treatments, such as appearances, physical abilities, and activity level, personal attributes, such as being healthy and independent always. People who ran marathons, and when they get cancers, they feel dejected that I did everything healthy, but now look at me today. Even for going from the bed to the washroom, I have to depend on somebody. Role and identity within your family in your work life is very important. I have seen on the airport, and I had almost got into a fight with one of the flight attendant. When there was one lady who had come, obviously I could make out that she had alopecia, her hair was sparse, and that she would have had some chemotherapy. Looking at that patient, we can make out. And then that flight attendant told that you have not got a certificate from your doctor that you are fit to travel. So she singled out that patient from all the people in front of the crowd, and it was very embarrassing for the patient. So that is why maintaining self-esteem is very important, that even if appearances do suggest or they do give way, we have to find that coping mechanism also to maintain our self-esteem. Coming to terms with mortality. Now, as I told you that there are patients of cancer we know who are not going to make it eventually, especially when the disease is in advanced stage. So they should also have the peace of knowing that their death from cancer, if it comes to that, will not obliterate the meaning, value, and joy that their life has given to them and their loved ones. So you always reflect and say that, okay, I had a good time. I should be thankful to God for giving me that good time. My end could have come in any way, but whatever time on earth that I had, I really enjoyed it. And they should be thankful for, or they should be grateful to God, or in whatever they believe, whether it is God or any other power that they believe, that the end of their life was just a matter that had to happen, but the time that they had on the earth was very good. So this was something about the coping mechanisms in the patients, but stress in the nursing staff. I am just taking one more slide for nursing staff. Is again too much. It's not just from the patients, it's from their relatives, it is from doctors like us also, because so many things you people have to manage. So you really have the burden of carrying all these emotions on your back. So stressors, consequences of stress, and factors that moderate these consequences are also well identified. So you also should see how you can cope up. Confrontation, you can talk to us and say that, okay, doctor, you did tell me that I did not do this, but why I did not do this was because of this particular reason. So self-control, obviously that is important for everybody. Social support, responsibility, acceptance, escape avoidance. That you are not trying to look into that person because that person scolded you 2 days back. So don't do that also. Problem solving. Always we say, no, if somebody comes to us with some problem, we always say that you have come with a problem, you tell me a solution also. So don't just tell the problem, tell a solution as well. And positive reappraisal. So training in communication and management skills, develop supportive, collaborative work relationships. And there was this researcher Cohen, he reported that when oncology nurses are able to articulate the meaning of their work and understand how these meanings affect patient care, they are more satisfied with their jobs. So I think that is what is important. So wishing you a great day. Thank you.
Because when I put them into oncology, their face becomes small. That's why I would like you to speak a few words on that.
I think it is the nursing staff who should say that. I would want everybody to come to oncology. But I don't really know why they are scared. It's like any other nursing. It's just that we always stress that make sure the IV line is good and make sure that the drug has gone in half an hour and not in 5 hours. So when such things happen, even everybody would definitely point that out. It doesn't mean that we are scolding them, but it is pointing that out, which is true for every discipline, not just oncology. But I think this is what the coping requires. The nursing staff has to learn to cope up, how to cope up with the cancer patients. They feel that the patient must be depressed, very sick, and if I go and tend to that patient, I'm just thinking, even I might feel a little disturbed, my day may not go so well, especially compared to the neonatal wards, where you are seeing nice chubby babies who are crying and smiling and everything. Probably, that's what I feel so. Okay. Thank you all very much.
Thank you so much, ma'am. I can say Dr. Poonam is our mother of oncology team. Thank you once again, ma'am. Always your wording, no, it's like a motivation for us. I request Sister Saraswati to come forward to honor Madam Poonam with a memento. Now, may I invite Ms. Shraddha from Weekend Team Lead to come and speak about the coping strategy from the patient views as well as the nursing view.
But will the straight thing go in? Is this round? Okay. Let's hope the laptop doesn't switch off. Can you switch on the project? the lights.
Thank you. Hi, good afternoon. Can everyone see me? I'm a bit short, so I don't know if you can see me clearly. But my name is Shraddha, right? And I'm part of We Can, which is basically Manipal Hospitals Cancer Survivor Support Group. So I'm a caregiver, right? My father was a cancer patient, and he's a product of Manipal Hospitals. He's right here, and we work together to take care of cancer patients' emotions, right? So, one second, there's something wrong. Okay. Can you just check if it's tight? Yeah, can you just, if you can. So I'm actually gonna request him to come and start off and talk to all of us, post which I'll talk to you, yeah? Mr. Salil Jain, if we could have you. Thanks. I don't know, some loose connections. I think if you touch this. I have email. Okay. Okay, I'll just 1 second. Yeah. I'll just mail, hold on. Sorry guys, technical problem. Just give us 2 minutes.
Listening to the doctors, and here I am, a cancer survivor. Very much out of my path. I got rectal cancer in 2003, and well, I'm doing absolutely fine. Thanks to Dr. Somshekhar and his team. I was robotic surgery here itself, Dr. Amit. So life has been wonderful. Now, what happened was that as I went through the journey, cancer journey, what I observed was that most of us, the moment we are told that we have cancer, we break down. Not only we, not only as a patient, my family also breaks down. And it leads to a lot of, I would say, misery in terms of emotional upheavals. So before we reach the hospital and we meet the doctors and then later on the nurses, we have already undergone, or we are quite a bit in pain, because even today
cancer is equal to death. This is what is generally there. Now, a whole lot of people have come across cancer for the first time. I mean, those who have had the opportunity of going through it because of somebody else, they have different ideas. But then, most of the people who have come in contact with cancer for the first time, they have already had a death, I would say, in terms of absolute total emotional trauma and upheavals. So, it becomes very, very important for us to make it clear to the patient as well as the family that cancer is not what they think it to be. The perception is wrong about cancer. In fact, I tell many people that, look, cancer is better than heart attack. Why? Heart attack will take you away, yaar. The Yamraj comes and tells you, hey, come on, let's go, and you have to go. But what about cancer? Cancer gives you all the time, right? Gives you all the time to spend time with your family, gives you all the time to do financial planning, gives you the family the time to accept that, yes, oh, he's going to go. So therefore, even if he has to go, even then, it's better than heart attack. So therefore, when we are dealing with patients in our oncology, we must tell them that, look, it's not that bad as you think it to be. It isn't that bad, actually. So that's the way it is. So therefore, we got into this. I told Dr. Somshekhar that, look, we need to have this support system also for the cancer patients. In fact, very first time that I counseled a patient was out of my bed here itself, because there was a patient who was not willing to, he was very, very afraid of getting into an operation. So Dr. Som saw my attitude and he said, look, Mr. Jain, why don't you talk to this lady and the family? So I talked to that lady and family, and 45 minutes, I actually got out of my bed and I sat down on a chair. I said, look, let me not talk to somebody who's afraid, lying on the bed. So I sat up the very next day of the operation, and then I counseled them, and she got her surgery done. Within 2-3 days, she got herself admitted. And the best part is that I was still in the hospital. She came, got herself operated, and went back because I had some complications. So that was the fun of it, right? So the journey for me started from that time. And ever since that time, I have been talking to so many cancer patients and survivors as to how to handle it, how to go about it without fear. Because that fear is the problem. The problem number one is the fear. Now, fear is of death, of pain, treatment, unknown, everything. So therefore, that is what happened. And out of this, because we were getting good results, and I've been getting a lot of patients here for treatment. In my family and friends, people came to know about me, and then they contact me whenever they get cancer. So I have been, counseling and bringing them here. So we thought, why not we have a department here? So we were discussing with Somshekhar sir, and then ultimately we felt that yes, maybe management also felt that a separate support team, if it is started, then it may be good. So that's how it all started in 2019. We-Can, Manipal Hospital formed the We-Can, launched it, and they said, Mr. Jain, will you participate? I said, okay. So that's how it all has started. And basically, it is a cancer survivor support group where we are giving support to all the survivors. Now, see, the word survivor internationally, the definition is a person is called a cancer survivor right from the date of diagnosis till his last breath. So all of us, the cancer patients, right from the day one. So actually, everybody who's here is a cancer survivor. We call them patients, but then actually they should be addressed as survivors internationally. And survivors, somewhere, if you're being called as a patient, somewhere it hits a patient, right? So if I'm called a survivor, it gives me better hope that yes, I'm not a patient here, I can do it. And that's how the name We Can also came in. Yes, we can do it. That was the idea of the hospital, and we did it. So it's a wonderful thing that has happened, and we are doing this. So the whole idea is that give the emotional support to the cancer survivors all throughout their journey, right from the time of diagnosis, during the treatment, and also post-treatment. See, because as all of you know, cancer is not a one-day affair. If I am diagnosed with cancer, it's still my last breath. I don't know when it is going to come back. Nobody can give me a guarantee that it won't. We are having so many cases after 8 years, 10 years, 20 years, it comes back. So therefore, if we build a relationship with the patient, right from the time that they come to post-treatment also, then that is what is the requirement of our cancer services that we can offer. So therefore, what we are doing now, at the time of diagnosis, we are dealing with it. Shraddha will take you through all that journey. Then during the treatment, what all has to be done, and also post-treatment. Because see, the cancer care doesn't finish just by treatment ending. It has to continue beyond that. Because as we all know, 5 years is in any case, they should keep following up. So that is there in any case, and beyond that also. So if nothing else, at least for 5 years, we should try and keep in touch and have them back coming to us for follow-ups. So therefore, this is the way the whole thing has been planned, that we must hold hand and we must become their friends right from the time of diagnosis beyond. So Shraddha will take you for the balance. Thank you very much. Thank you.
Hi, I'm back. So sorry, there's some technical problems. Our presentation is a PDF right now. Okay. So yeah, first of all, I'd actually, I think this is the first time that I'm getting a chance to say thank you so much to all the nurses, because my first experience of how important nursing was when my dad was getting treated here. And Sister Maggie was actually the sister who took care of, my father and all of us at that point in time. And to be very honest, as nurses, maybe, you look at it as, oh, there are so many patients, you probably don't even remember all of us, right? But for us, Sister Maggie was like this little angel, and every time we came in, we looked forward to meeting her, to what she would say, would she give us a tip on how we need to take care of him, whether it's his nutrition or, the way we were dealing with our emotions as well at that point in time. So to be honest, as a family, we really looked forward to our interaction with our nurses. That's how important it is, right? That's how important your role is in the journey of, a cancer survivor and their family, right? So first of all, what is We Can? I think Mr. Jain has kind of touched upon it as well, right? So Manipal started this cancer survivor support group, right, in 2019 to address this emotional need of patients, right? Now, it's a need that requires a lot of time to be spent with them, right? And it's not possible for nurses and doctors to say, hey, you know what, let's just leave everything and address all of their concerns, right? It's not possible to do that. We spend sometimes 2 hours with patients addressing, their fears, their concerns, their needs. Now, if we start doing that as nurses and doctors, who's going to treat the patient? So we need your skill to be able to help treat the patients. But at the same time, we need to be able to build that emotional bond with the patient where we strike that, that immediate bond that comes in. So then they kind of look forward to the nurses, to us to come, and they know that, hey, Manipal is an institute where it's not just medical treatment, but it's patient care, right? That's what, we're looking at. Okay, one second. How do I? Okay, sorry, I'm going to have to scroll. Okay. Right, so what is We Can exactly, right? We Can is the in-house cancer survivor support group of Manipal Hospital, which was established in 2019. So gone are the days where patients of Manipal need to go out and try and figure out, where do I need to get help, right? Who can counsel me? Who can help me with my doubts, right? You actually have a team sitting within the premises of this hospital who can meet a patient every single time they step foot into this hospital, right? So that's the service that Manipal is providing, right? And We Can runs the wellness and the survivorship program for all the oncology patients, right? So what happens, right? Like he explained, internationally what happens, the word survivor is not used for someone who's finished treatment, right? But actually from the time of diagnosis till a patient's last breath, they're actually not called patients, they're called survivors, which is why We Can is called the We Can Survivor Support Group, which means that we provide support from the time of diagnosis, during treatment, and post-treatment, yeah? So what is cancer, wellness, and survivorship? So wellness and survivorship, I'm literally going to read this out first, is to hand-hold the survivor and the caregiver, right? Now, the caregiver can be a family, a friend, anyone who's coming to take care of this cancer survivor across medical, emotional, psychological, physical, as well as social rehabilitation. And this is all of these things are part of the journey of a cancer survivor from the time of diagnosis until treatment gets over and even beyond that, right? So this is exactly what it is. So what is the survivor journey, right? So what happens? A patient comes to the hospital with a complaint, right? He meets the oncologist sends him for a couple of tests. Now, either he has a tumor that's malignant or it's not malignant, right? Now, if it's not malignant, we don't even come into that picture, right? But if it is malignant and he comes into the care of an oncologist, what happens? He's told that, hey, you know what? You're diagnosed with cancer. Now, what do you think happens at that point in time to a patient and the family? Does anyone expect to get a diagnosis like, hey, you have cancer? Does anyone want it? Do you think anyone wants it? No, right? And no one's expecting it either. So it's actually a really big shock. And honestly, I went through it. When my father was diagnosed with cancer about 9 years ago, I wasn't even in Bangalore at that point in time. I was traveling on work. And I remember just sitting in the hotel room and I cried and I cried and I cried. And the reason that I cried was because the only thought that came to my mind is, I'm going to lose him. He's not going to be with me anymore. Right? I didn't even think that, listen, there's cure, there's treatment, right? And this is what families go through, what patients go through. And I flew down to Bangalore, I canceled all my meetings, and it was almost like, oh my God, we need to get into treatment today, tomorrow, we have to get this out, what do we do, where do we go, what are the things that we need to take care of at this point in time? And when I met my father, when I came down to Bangalore, he looked at me and he said, what are you so worried about? It's just cancer. And I was like, what? I thought he's gone crazy. I was like, oh, you know, this grief has taken over him so much, he doesn't know what he's saying. But actually, that was his positive attitude. And I didn't realize it at that point in time. You know, that how important this positive attitude of his is going to be in his recovery. I actually got my strength from him, right? And that was the biggest advantage I had, to be honest, as a caregiver. I didn't need to give strength, I got it from him, right? And this is what happens to cancer patients and their families, right? So what happens? First of all, there are so many medical terminologies that you just don't understand. It's the first time you're listening to these things. There are names of so many different tests, right? And they're just like, it's like a whirlpool of, like, it's a different world altogether, and they just don't know how to navigate through this, right? Like the doctor said, the first thing they do is to go on to Google. And honestly, that confuses them even more. You know, because different websites give you different information, it has different kinds of knowledge. And as a patient or a caregiver or a layman who doesn't have medical knowledge, you're just like, but who's right? Is the doctor right? Is Google right? Is this site right? Or is my friend right? So many friends and family come to help you in good intention. But actually, it's very harmful for the cancer patient and their family because it's confusing them even more. You know, someone will say, hey, don't do chemotherapy, you know, it'll kill your organs. Someone will say, do Ayurvedic. You know, there's so many opinions. What happens at this point in time is that a cancer patient and the family are totally lost. They're completely in shock. This is their journey. They don't know what to do. They don't know who to go to for treatment. They don't know where the right information is. Right? They're totally lost. And this is the state in which they come to us. When someone is diagnosed with cancer, this is the state in which they come to us. And from this point, we need to handhold them to even explain to them what is cancer. A lot of them think it's an infection. And they can take antibiotics and, you know, they should be fine. Right? So right from explaining to them what is cancer, what is going to happen to you, addressing their fears of death. You know, they think, oh, now my family is going to suffer, my kids are going to suffer, I'm not going to be around. Their first thought is, I'm not going to be around. So first of all, to even make them understand, look, it's not like you're not going to be around. 95% of patients today are getting cured, you know, so there is a possibility of cure, but you need to take the right decisions at the right time. Right? You need to go to the right doctors. You need to have the right kind of nursing staff who's taking care of you while you're going through treatment so you get the right treatment. These things are important, right? So we have to explain this to them and then kind of allay all of their fears. You know, they have so many concerns about finances, you know, teach them how to deal with these things, right? And teach the families how to deal with them. What happens many times, even if the patient is not worried, because the family members are so worried and worked up, it rubs off on the patient. So even if the patient is a bit confident, he loses it. You know, so even teaching the family members how to deal with it, yeah? Okay, so then what happens? They say, okay, you know what, great, I have to take treatment, right? And they begin their treatment. But what happens when they're going through treatment? It's another ball game altogether when they're going through treatment. They've accepted that, yeah, okay, fine, you know, this has happened to me. Then suddenly they're like, oh my God, I'm so scared, chemotherapy side effects. Oh my God, I'm going to go through surgery. What if I die on the operation table and I never come back at all? That's the level of fear, right? And this is the journey of the cancer patient, right? At every single stage, they need someone to handhold them, talk to them, explain to them what's going to happen, what's not going to happen. You're not going to die on the operation, table if you're going to go for a breast cancer surgery. You're going to come back feeling better and without the tumor and without the disease, right? So we need to explain these things to them, right? Now, for example, if someone has a stoma, they're so worried. They think, oh my God, my life has changed. My father is living on a stoma. Can anyone even make out sitting in this room? You can't, right? He's been living on a stoma for the past 9 years, right? Honestly, when I heard about it the first time, I was also like, no ways, do whatever you can to not have this stoma. And then when my dad just did one thing. He took me to Dr. Somshekhar and he said, you ask this question to Dr. Somshekhar. And I actually did. I said, doctor, can we not do anything to not have this stoma? He said, yeah, you can do. Allow your father to live with cancer instead. Right? So I understood that the choice was very clear. Either you live a normal life and get used to a stoma, or you live with the disease. Right? And this is the journey of the cancer family, right? This is what they need to understand. These are the things that they need to deal with and they need to understand, right? So one is surgery. When it comes to chemo, I think all of us know very well over here what are the fears that they, they go through during chemotherapy. We've had patients who say, I don't know why I'm taking chemotherapy. It's a poison. It's going to kill my body and my organs. Anyways, I'm going to die after this. So these are the misconceptions that, patients have, and this is the state that they're in. What happens, they say, the doctor comes, he gives medication and he goes. The nurse comes, she injects the medication and she goes. The rest of the time, the family and the patient are just left on their own, in a state of fear, in a state of depression, in a state of anxiety. They don't know how to deal with things. They're making the wrong decisions. They're taking advice from the wrong people. So when we go and we meet them and we talk to them and we understand what is going on and we provide solutions to them, we've had patients literally who cry to us and tell us, no one till today has ever come and asked us, how are you actually doing? How does it feel to be here? Can I help you with something? How do I alleviate that emotional pain that you're going through at this point in time? Right? So this is the journey of a cancer patient and a survivor. And other things, right? For example, the stress that you get because of going through side effects. Like we say, oh, you know what, you're vomiting, just take medication. No, it doesn't end at that. Imagine the trauma of running to the bathroom when you're so weak, running to the bathroom so many times just to go and throw up. And then you're feeling weaker and weaker and weaker. And the family's like, oh my God, I don't know what to do. I don't know how I'm supposed to help him out or help her out. I just don't know how to do this. And they feel so helpless. And this feeling of helplessness and this feeling of fear of, something wrong, they think, oh, she's vomiting. That means this medication is not working. That means the wrong treatment is happening. Let's move to Ayurveda. So this is the state in which patients are and, in which the families are. And these are the kind of things we need to deal with when we're dealing with them while they're going through treatment, right? Now, post-treatment, right? What happens? Once treatment gets over, we think our job is done, right? Surgery is over, radiation is over, chemo is over, we're done, okay? But the truth is we're not done, because now they have to be educated about what are the things they need to do to try and reduce the chance of recurrence. The biggest fear for patients and their families at this point in time is recurrence. Oh my God, it will come back anytime. They get a cough and they'll come back and ask the doctor, is it lung cancer? Like, I'm having a cough for 2 days, is it lung cancer? So they need to understand that it's not. They need to get back to normal life. They need to take the right measures at this point in time. We have to bring up their confidence levels. We have to prepare them to face society. Most of them don't want to go back and meet their friends. They don't want to live a normal life, right? And this is where we need to help them. The other thing, suppose it's end of life, right? It's not cured. It's end of life, or it's not remission, right? It's end of life. What happens? We actually have to make them accept that they have to live with pain. And imagine how difficult that is. For a patient and a family to know you have to live with this pain, right? And that's where we need to help them out, right? Or accept that, listen, this person is not going to be around anymore. How do we make them accept death? That's a very big part of, helping cancer patients out when it comes to end of life, right? And more importantly, at that point in time, the patient is half the time not even aware, not even in their senses, because all the medications that, that is going in because of that. The caregiver is breaking down all the time, right? And that's where the caregiver needs, that's where the caregiver needs a lot of help, right? So this is pretty much the journey of a cancer patient and their family, or I would like to say a cancer survivor and their family. And these are the things that, these are the areas in which we come and we help out, right? So if at any point in time you come across a patient where you feel like they're becoming weak or they need emotional help or they're confused, please put them in touch with us. Okay, if you look at your pens, there's a phone number given on the pen. That's my number, right? So you'll have it with you at all points in time. Get in touch with us, put the patient in touch with us, call us, and we'll sort it out. Yeah, any questions? Anything at all? Okay, thank you.
Thank you, Shraddha, for very, very motivating words. I would request Ms. Haripriya to honor Ms. Shraddha with the memento. I request Ms. Maggie to honor Shraddha with the memento. Shraddha, kindly come forward. The last is always the best. Before we wind up for the break for the lunch, we have one interesting session by Dr. Rohit. May I invite very eminent Dr. Rohit C, consultant surgical oncology, to take us through hyperthermic intraperitoneal therapy, chemotherapy. Let's give all our ears for a very informative session. I would request Ms. Judith Watson to welcome Dr. Murali Srinivas with the bouquet. I would request Dr. Murali Srinivas to speak a few words.
Good afternoon, everyone. Why the volume is very low? The lunch is still yet to be served, right? Yes. Okay, I think so. We always have, there is a, even postprandial somnolescence is something which all of us know. After food, a sumptuous meal, we go for a, we tend to dose. There is also a when you're fasting also, you tend to be a little sleepy. So I don't want to, be a block between the lunch or the next session and your meaning between lunch. I don't want to be a block there, but just wanted to congratulate Mrs. Judith and everyone else who has been part of this thought process first to have a program like this. A hearty congratulations and a big congratulations to each and every one of you who have come here to attend this program. Meaning it's truly heartening to see, training programs. See, always in life, there is a saying, if you want to improve quality, all of us want to improve quality, yes or no? Quality means our own quality. The quality is of multiple things, quality of a product, quality of our service. So today, if I am a neurologist, I want to myself improve, or if I am an administrator, I would want to acquire something to, or whatever, do something to improve upon whatever I am doing better than what I have done yesterday. All of you agree with me? Yes, sir. Yes, that is what is there in our mind. So there are 3 things you need to do for that. Can anyone say what are the 3 things? Training? No. Yes. So I think the people have listened to me. This must have been from MHB. So it's only 3 things are training, training, and training. So I think, the more we learn, so there are 2 important things in this training. One is the interest to learn. Most of us would have. So what happens is, we will come, we have an interest, we want to know, it is that curiosity of the unknown. We don't know something, so what is happening new? What is else in a chemotherapy can happen? So one is the curiosity of the unknown. You come and we tend to learn a few things. Second, what happens when we learn, I'm sure today when you are learning, it would happen that you will take down notes and say, look at, I want to go and read up on this. I want to do this. I want to implement this. This is something. And when you're reading that, you'll also get more ideas. No, why not I do that? Why not I do this? All would come. But 80% of the times what happens? After we go back home, today evening it will be there, tomorrow it would be there. As days goes, it wanes because we are gone into our lot of other mundane work, regular work. This tends to take a back seat. So my only request to all of you is, take this as you are taking it very seriously today. Continue to take this for the next 3 weeks. So something if you take for 3 weeks, so 21 days, then it gets imbibed into your system. Even in whether it is a habit or something, some people say 42 days, but even as early as. So for a human mind to even, for you to remember something, for you to have this something stored in your memory, you need to something called as, in addition to understanding, you also have to recollect or reflect on it. So the only request what I am trying to tell is that after you go home today, it is fresh, it will be fresh in your mind. You may be from chemotherapy, you may be from non-chemotherapy, you may be from any place, but try to have a plan put for yourself. Look, even if I am from a non-chemotherapy, these are the learning things for me today. Tomorrow if I go to chemotherapy, that will be useful. So how can I put even now in this? Like I'll give you an example. Suppose they teach something on labeling. You may not be doing it on a normal, you don't need to do it. But if that is going to improve quality, why not I do it? You can talk to your supervisor and say, look, madam, I learned this. I want to implement this also in addition to this. Nobody is going to say that I'm going to give you a better quality. Is it okay? Nobody is going to say you have to follow only that A, B, C, D. You cannot do E. If E is going to improve the, meaning we are not in that world. Today, everybody wants improvement. Everybody wants. So all I'm trying to tell is go back, reflect and see how you can, have this in your day-to-day functioning, and every week spend at least 15 minutes to half an hour and see what I have done, how I could do. Because any training program, unless we put into use and put into practice and get part of our DNA, it is good, you would have learned something, but you would not achieve the full potential of the training program. So that is the only request I have. This is a phenomenal crowd. It's a wonderful topic. I would have loved to be here, for the whole topic, but various other reasons. So I always feel, we should never stop learning. Throughout our life we should be learning, because only then that will also good for your mind. It will postpone or prolong your Alzheimer's, and more importantly, it will also keep you relevant. See, all of us, just a couple of points before I say, how many of you have used Nokia phones? Everybody would have at least seen it. Today, when Nokia phone, when whoever was using Nokia phone at that time would have been proud about it? would have thought that this phone is what is going to be, part of my life. But today what has happened to Nokia? It's not there. Why it is not there? So, they didn't do anything wrong. They tried innovation, but they thought, look, I have a wonderful product. People like it, it's beautiful. And, they did not bother about the changing environment. Yeah, someone said innovation, that's also a right thing. Changing environment, what is happening? In that change environment, what is it that the people want? What is it that what the competitors are doing? What are the expectations of the customers? What is the perception happening, and so on and so forth? By the time they realized, it was too late, and many others took over. So the same thing, so unless, what happens is, unless we all start thinking a little, differently. See, nursing is, as Mr. Karthik always says, nursing is one of the few, areas which has not undergone a drastic transformation in terms of how your day-to-day things go, what it was 20 years and today. See, what it was 20 years, all of us used to go in a, ambassador or in a maximum in a Maruti. Today, most of us want an automatic car. That is a transformation, not just the vehicle. It is so today, it is not that, although we have been talking about it, that 20 years back we said, look, I want to go give a medicine, I will take an iPad there, I will show the iPad and say this is the person, it will identify the person, it will tell these are the medicines, I will give the medicine, every time I give, I will say as and when I am giving, I will say yes, 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 and it gets updated. This is all what we dreamt 10 years back, and unfortunately it still continues to be a dream. Various reasons, I am not saying that has probably nothing to do with nursing, this may be IT. So unless we keep thinking out of the box for achieving that same goal, then we may continue, it may take a longer time. So wonderful that such a program is being held, very niche specialty. Wishing you all the best, and as I said, only request is don't stop this. The learnings please implement, and you should get at least 120% out of what you learned today. All the best. Thank you for calling me here.
Thank you so much for your inspiring words, sir, as always. I would request Ms. Linda Moll to honor Dr. Murli with the memento. May I request Dr. Murli to honor Dr. Rohit with the bouquet and memento. Thank you, sir. Thank you, sir. Thank you so much. I would call Dr. Rohit to take us through the session.
Okay, so I have a huge task ahead. Let me see how much justice I'll make. Just to fill up energy, can I have some 5-6 claps? Just move down, that's all. Okay. Yes. So I'll be talking on a very new topic, which is very close and dear to our team to tell actually. the surgical onco or entire comprehensive Manipal Comprehensive Cancer Center. It was about HIPEC and nursing care. So what is HIPEC? I'll just tell in detail later on, but in short it is hyperthermic intraperitoneal chemotherapy. So what is the relation of HIPEC and nursing care? When you think over, this is what great Hippocrates said, that diseases which medicines do not cure, iron cures them. And those which iron cannot cure, fire cures. So here we introduce our HIPEC. HIPEC is heat, so I assume it to be a fire. And those which fire cannot cure are to be reckoned wholly incurable. So if something a fire cannot cure, then it is thought to be incurable. And that point of time, who walks in? So things that are incurable are only managed with, we know that, TLC, that is our tender loving care, and there is no one else who can give this better than you all. So this is how I would relate our HIPEC and nursing care and begin off my talk. So my objectives will be, I'll be speaking through little about HIPEC, just to say what is the struggle that goes through that process of surgery to bring about, to get the patient in, what are the process they undergo. And then I will talk in particularly about what are the practical aspects which I felt, because I finished my training here from 2014 to 2017 as residents. So I have many sisters who I have worked with them. We have early morning for rounds when we have come, we have shouted too much on them. Many younger sisters are there, most of them are there, we have taught them, we have had lunch with them. So in those practical aspects, what are the things that I felt which they could have also picked up along with me? And now I'll be talking about those things, especially in consultations with preoperative. Intraoperative consultations is mainly for people who are going for OT assisting and for those patients, and postoperative care. And ultimately, it is always about the team. If the team doesn't work together, then everything will collapse. It's always about the team. So I would start off with this to allow yourself to be a beginner always, because no one starts off being excellent. So before knowing what is HIPEC, we need to know two important concepts, that is peritoneal cavity and peritoneal surface malignancy, and then about surgery. So peritoneal cavity or peritoneum, most of you know, is a potential space in our body which contains all the abdomen and pelvic organs. And that cavity is lined by a single layer of peritoneum, which has got a smooth, transparent serous membrane. It lines the entire abdominal organ. So peritoneal surface malignancy, as I mentioned here, involves any cancer that is gone and deposited on the surface of the peritoneum. So if I assume myself to be an organ and the shirt has to be a peritoneum, anything that comes and sits on this is to be assumed as a cancer deposit on this. So for a long term, I would not bore you about all this thing. The only important thing what you have to see is the last point, where historically any patient, if he has been diagnosed with peritoneal carcinomatosis or peritoneal mets, maximum they would tell directly is that you will not cross more than 1 year. They were labeled almost inoperable or untreatable, and they were just pushed towards palliative therapy. So what changed the entire scenario is that, to think that peritoneum is also a local organ, like stomach is one organ, intestine is an organ. So you also assume that peritoneum, that is covering everything, is also an organ. And since it is only in the abdomen, anything that stays within the abdomen can be removed. So then what we do is, we come up with multiple surgical procedures and remove all those things. So those includes peritonectomies, multivisceral dissections, all those things. Then we add intraperitoneal chemotherapy. That is, after the surgically, we remove all the tumor. So whatever is visible to our eyes, we remove everything. What is not visible or microscopic diseases, we treat with intraperitoneal chemotherapy and heat. So we add heat to that. So why is heat important? What does heat actually does extra when we do more than intraperitoneal chemotherapy? Heat will actually break down the cellular membrane of the cell. It will allow for more penetration of chemotherapy within that area, and immediately after surgery we have a very receptive area where immediately chemotherapy can act. So all this together, they compromise the HIPEC procedures. So what we expected out of it is to improve the survival of the patient, and also simultaneously with so much morbidity, so much procedures being done, there is increase in the morbidity and mortality. So I have put this HIPEC to end with C, that means complications ahead. This is how most of them start off. When initially HIPEC came into existence, it was around 1980 or something it was started. It was started off in USA by one of the pioneer called Sugar Baker. So when he started off, everybody used to, dethrone him so much that it was written in New York Times that people who practice HIPEC should be hanged. It is such an extreme surgery that they are going to harm patients more than curing them. During that struggle, he picked up and pushed it, and his struggle and many other people who pushed on for more than 2 to 3 decades, that this procedure has come to existence. And in India, we are very proud that we are one of the first institutes in entire India who started off this program right around 2010 or 2011. It was a very tough task for head also, but we have gone through those things, and we have trained almost most of the surgeons in entire India. Not only surgeons, we have got many nursing teams, many technician teams which we have trained. Our own teams have gone there and trained them also. So this is what we see, what I meant peritoneal surface. This is the disease that we see. This is what we see. As soon as we open this, you can assume that most of them will tell there is nothing you can do for this patient. You can just close the abdomen and come out. But as soon as we see something like this, first line that we get from our boss, Somshika sir, is that today we are having a great party. Okay? So we start off the party in teams. This is what we see. This is on the omentum deposits. This is the amount of disease that you see on the omentum. Same thing on the liver. You can see how we have almost removed everything on the liver now. See this entire thing is cleaned. This takes in so much mental effort. It is not only for me, it is for the same amount that stress the sister who is standing beside me also takes. So anybody who is going to stand for this procedure will agree that it is a very daunting task. So anybody who comes to OT new in our OT setup, first question they ask, anybody who wants to lose weight, go to oncology department. Others all go to other departments. Okay? So you can imagine how much it takes. Each surgery takes at least for about 8 to 10 hours. So morning by around 6 o'clock or 7 o'clock if we start, it ends by evening 7 o'clock or 8 o'clock, not before that. Okay? So this is the amount of effort. This is all the disease. This is what we see, and this is all it entails. We remove uterus together, colon together. This is the omentum. So this is the surface of the liver. You can see the liver being bared there. We remove the surface of liver like that. Okay? This is the amount of disease on the intestine mesentery. So this is the amount of disease. Then look at it. We strip it. We go turn by turn as a team, and we keep removing it. This is what we see at the end of the day. Okay? So once we remove all the disease that is seen to the eyes, then whatever microscopic disease is left behind, for that we do HIPEC. So what we do is, after the procedure is done, we bring out make a abdomen like one cavity. We place 2 tubes. 2 tubes will go inside. There are the inlet and 2 are outlet. So from the inlet, what happens is, this is how the everything setup comes in. So from the inlet, we have a special dedicated machines for that. Through the machine, a chemotherapy drug is important that is pushed into a heated solution, and the drug with heat goes into abdominal cavity. It circulates in the abdominal cavity for 90 minutes. That is the standard time that we do. So during the process of that circulation, so the intestines will be there. Then the solution turns around the stomach, as in how you cook your sambar. Okay? So sir calls it cooking your Chinese noodles. So we have one of our sisters or one of us standing beside the patient and moving the intestine. So however you cook your intestine at your home on Sunday, same day you do on the OT. Okay? So this is how we cover the surface. Once we reach a temperature of around 41 degrees Celsius in the heat, then through that heat, the solution goes inside. This is the drug that is being added, that is blue color, can you see there? So what does heat do is about this. It acts and it improves the chemotherapy efficacy also, and it also makes the chemotherapy cells more susceptible for chemotherapy. So this is how, so from the pump, heated solution goes inside, and then acts there, and then the solution is drained out. At the end of 1.5 hours, everything is washed out and removed. So this is in simple terms, HIPEC, that is, I have added intraoperative just for more understanding. So once tumor has been removed, a sterilized chemotherapy solution is delivered to the abdomen at a heat of about 41 to 42 degrees Celsius. Okay, now starts what is important as a preoperative care. So preoperative care starts from the day patient walks into OPD, when most of our, when we have a, the nursing team that is established, that has been brought up as a new, new setup for us, wherein we have a sister there, because it's a very big decision for the patient, and the trauma that they undergo at that point of time is too much. So for them to prepare for that surgery, we have prehabilitation. That is, they have to have a nutrition counseling, they have to meet the cardiologist, pulmonologist, go to ECG room, give blood, everything. So what we have started in our setup is to have a sister who can assist them and go and make the walk through the solution, through the departments very easier. So we have Sister Nabanita who is there with us all the time. She makes so simple and so smoothful that every patient, they don't even understand that they have gone through so many departments in the entire hospital and they have finished off everything, which is the most important part for them to go through, because they have to prepare for surgery. So once they are prepared for surgery, then they get admitted. So the day before surgery, most important thing is, as a sisters, most of you will be there besides them all the time. So the way you talk to them, the way you address their anxiety is more important. The other important thing why we don't allow, we admit the patient one day before is, and also as I told, the role of Sister Nabanita and other sisters who are there in that role, is that they finish off everything before the patient comes to ward. So once the patient comes to ward, all they do is just relax the previous day. That itself cuts down so much stress to the patient that when they come to OT that day morning, they feel so fresh. And that is more important for a surgeon or anybody for us to see, that the patient is so fresh that overnight they didn't have to go to some ECG room, or they didn't have to run for an echo room at night 10 o'clock. They didn't have to draw blood at 11 o'clock or 12 o'clock. And that is how their sleep is disturbed. Once sleep is disturbed, everything goes haywire. The patient is not fresh, they undergo so much stress, and at the time of surgery, still more stress is added. So it becomes very much difficult for them to undergo. So that is why we try to avoid all excessive movements with the patient once they are admitted. They should have a very good night's sleep. As the sisters who are taking care, very important is to see what is the chemotherapy drug that is required for next day's HIPEC procedure, which is usually written by the medical onco team. They come and write the drug. So you have to see the drug, you have to see what is the concentration. Then along with that, you also need to document that they don't have allergy to this chemotherapy drug. Next important is what are the images they have done, what are the investigations they have done. I don't know if there are a few sisters, I cannot make out actually. I have actually made many sisters go and get the images and the documentations which patient is done. Because if they don't come with that, our imagination as a surgeon is only when we see the images. So without the images, it is difficult for us to operate, although we would have had a plan before. So as a sister who is taking care, as a nursing who is taking care of a patient who is going to undergo any surgical procedure, it is very important for you to have the document prior day itself sorted out. Tell them whatever images you have, keep it with you, so that we take everything to the surgeon there. Because without those images, there are many things that we can miss. So that's a very important part for us. Don't allow too many people to come and go outside, in and out of the OT, especially where HIPEC is going on or transplant is going on, something like that. And people are going to come inside, they are going to train well, you tell them eat and come nicely in the Surgical gloves. We wear a very long gloves or a double gloves that we usually wear. We also have now, anyway, N95 mask is already being used everywhere. Then we use goggles sometimes. And after that, how we handle the chemotherapy drugs intraoperatively. If there's any spill, how do you manage all those things? So intraoperatively, the chances of contamination is mainly fumes are coming. If you inhale fumes, then will that cause damage to you? Will the fumes cause damage to sisters or anybody who is assisting the surgeon there? Or while many instruments are there to take care of, many biological tissues to remove. So all those things should be taken into account. So these are many trials that have been done where they have removed samples from gloves or from the from the urine samples of doctors or sisters on the day of surgery when they have done a HIPEC, and they have seen that none of them had any detectable risk or chemotherapy in their body, which has been proved with any blood samples and all those things. So it is actually a safe procedure for all of us. Only thing, the daunting task is to stand for there and to undergo that physical trauma. So these are very few things. To start off with, we make sure that even if something spills, it is absorbed immediately. So we have a impervious mats being laid down on the floor to protect against surgical smoke, because lot of surgery undergoes, so much surgical smoke comes. For that we have smoke evacuators where the surgical smoke is sucked. Then for protective equipment, as I told, long gloves, goggles and N95 mask, everything is being used. Normally any new nursing who comes to assist in OT, we always make sure they understand the procedure what we go through. You tell them that this is what we are going to go through, this is what the chemotherapy will be, so nothing to worry, we are also handling all these things. Because suddenly when a new staff comes into OT to assist HIPEC, they'll be in all energy, they don't know that all these things are there, this is chemotherapy drug and all those things. They simply assume that is something new that is happening there. And it sounds like something very much fascinating. So before they enter or touch anything, we tell them this is what you have to do, don't touch these things, be careful about these drugs, when you touch machines and all, be careful, all those things. Only then they also understand and they go along with that. Next starts post-operative care. This is very much important and very close to me, because as a resident who was trained in this hospital for last 3 years in 2014 to 17, what I have gone through during my training as a resident, along with sisters who were there with me in the ward, many things are very practical in this, which I am going to talk about. Post-operative care is very much important. So all the patients usually who are undergo HIPEC, first day they usually go to ICU. They are in the ICU at least for 2 to 3 days. So a person who is in ICU receiving a HIPEC patient, what is important for you? As and when you start receiving, we have protocol set up. First thing you look is what are the lines they have. Where are the lines? Where is the IV line? Where is the central line? What lines is being connected to them? Next thing what they notice is the tubes. If you see any of the HIPEC patients, most of the sisters will tell they look like a Christmas tree, because patient will be here, you will have at least 2 or 3 tubes coming out of their body. So many tubes will be there. So you make account of how many tubes a patient has, where all the tubes are there, where is it placed exactly. Then where is the chest drain, especially ICD. I know there are many, I have talked to many senior sisters, especially about ICD care, how much we have, how much we had fought about ICD care, how small things make changes, very important. All those things I'm going to talk here. So as and when you receive, most important is to see, are the hemodynamically stable, all those things anyways people will do. The most important thing other than that will be to allow the family to come and see them at the end of the procedure when they come to ICU. That itself, once the patient sees the family and the family sees the patient, both are almost, they are understood, okay, he is already in safe hands now, he's come out surgically safe, and now half the burden is already done. Next, the onus is on the patient now to improve as and when to support for us also. So try to reduce noises in ICU as much as possible. And one more important thing, especially in ICU, what I would like to stress for people who are working in ICU is, you see the light. If you go and see our ICU, you can see there are 3 intensities of light which is specifically designed for that. So what is the impact of light when you sleep? You can imagine if you are sleeping in your room and imagine you have 3 bright lights shining on your face. Will anybody of you sleep? No. So why is it in our ICU or many of the ICUs, you have 3 different intensities of light. You have a very small light which you can put it especially in the evening time so that the patient doesn't get so much bright light. Whenever you have bright light shining on patient's face or your eyes, what happens is melatonin, that is important for sleep, is not produced. If that is not produced, patient will not sleep. If he doesn't sleep, he will not rest. If he doesn't rest, his stress will not come down. All the parameters will simultaneously go to a toss. And your job is going to become double and not simple. If the patient sleeps comfortably, even you are also going to get rest and do your job. So adjusting the lights in ICU setting is very much important. Many of the time I have come and spoken to them. During daytime, keep the light as bright as possible so that the patient knows that it is day. Because you don't have a window outside, the patient doesn't know today is day, today is night, they don't know the time. So keep telling time to the patient that this is time, this is the time, now it is 10 o'clock, now it is 11 o'clock. That's why we have put so much bright. Because they will not know today is evening or it is night or day or morning. That is very much important when you are beside the ICU. Apart from that, there are small things about tubes and all, which I will talk. So keep importance about light, very much important. Then when the patient is moved from ICU to ward, what next comes? The first thing is about pain management. So this is also very important point. Many sisters, as soon as when I go, many of them know, they come and smile at me, they know I am going to ask them, which they have not done. It is about visual analog score. I am not going to blame any of them because they have so much work to do, but this makes the job so much simpler. As and when, immediately when I go, I don't ask anything to the sister. I'll ask sister, what is the pain score? If they tell me 10 or 9, I'll tell, come with me, I'll go. I'll go and we'll speak this. So as and when we know if the pain score is 4 or 5 or 6 or 7 or 8, that is when you decide, okay, how much painkiller I can give to this patient. It's a very simpler tool. I know there's lot many things to happen at the same time, too many patients to take care. But if you have an idea of a pain score of one patient or that patient who is important, then you will know, okay, this patient will not require 3 to 4 doses of paracetamol, or they don't require PCA for a long time, they don't require epidural for a long time. So very important is pain score on day 1, 2, 3, especially for first 2-3 days. If you know that patient is comfortable, if he is pain free, then half your job is done. Patient is also comfortable, you are also happy. If you are pain free, you can imagine he won't call you again and again, come and see me, pain, pain, pain. So before a pain trigger happens to him, make sure you talk comfortably, give 10 minutes, tell him I have given you enough painkiller, you are going to be very comfortable. Even if you have pain, we have other painkillers which we will give it to you if you have pain. Then they will absolutely aram se sleep. So once they are comfortable, you are comfortable. Then you can make your job aram se. So we have PCA, most of the time all our patients will have patient control analgesia. So any patient who has got patient control analgesia, your role as a sister who is there bedside is to know when you should, especially about alarm, educating the patient about when to press that PCA pumps. It is timed for every 20 minutes, 20, 25, 30 minutes. Even if they simply keep on pressing, the drug will not go immediately. So you should know how a PCA works, and then only you can explain it to a sister or to a patient, and that is how they can use it better. Then next important is about positioning the patient. Many patients will have queries about, can I turn this side, can I turn that side? So as and when they come, immediately you take a patient attender, tell the patient, keep them comfortably, tell them you can turn this side, that side, you can sit up, you can bend your leg, all those things. Then they will not ask you again and again same questions. So take your time initially when patient comes. That itself will sort out everything. As I told, light is a very important part of nursing care, which all of you should know. Importance of light in nursing care as well as in your life also. To handle light properly in our life is very much important, how you get your sleep in the night. So I would want all of you to have a little knowledge about how to use light in your life. It's very much important. As and when you go towards end of the day, dim your lights. As and when you wake up early in the morning, you brighten the lights. It is very much important to trigger the biological clock in your body. So the more, that is why you talk about more about the blue screens, you watch your TV screens, mobile screens, you don't get sleep, is because whatever the light that comes out of those screens is going to stimulate your eyes. So once the eyes are stimulated, enough melatonin is not produced. If melatonin is not produced, you are not going to sleep properly. your sleep-wake cycle is going to get disturbed. That is why we tell to cut off your screens for last 1 to 2 hours. It's very much important, so I would want all of you to know more about light. I'm very happy to talk. Actually, this is one of my passions to talk about, especially light, food, exercise, relaxation techniques, all those things. Next is about chest physiotherapy. Is very much important, to do the tapping, to teach the patient attender that this is how you tap. You just tell them, they are very much scared. You tell them this is how you tap them, this is how you take a positioning. You teach them to do spirometry. Any patient who are there, the first day I come, I tell them, this is how you have to do spirometry. I give them one page. Every 2 hours, you tell me how many times you have done this. I'm going to come and see you tomorrow morning and see how many times you have done this or not done this. So as a sister or nursing who is there bedside, your only job is the first day you take some time. If you take time only initially, then they don't trouble you again and again. Next is about mobility. As and when they come to, you tell them that keep moving your limbs up and down. And every day you tell them. Most common thing that happens clinically, practical is, a patient is on bed for a long time, they suddenly get up and they start walking. And they'll come and tell you I'm having giddiness. This is, all of us would have noticed this. So when a patient is there on the bed for a long time, first thing you tell them, don't start walking immediately you stand off. What happens? What happens is vasovagal shock. So patient is supine, suddenly they stand up, all the blood pulls in the leg. There is no enough circulation, they have a shock, vasovagal shock. So you tell the patient, as and when you stand up, just sit on the bed first. Next, as and when you sit, just stand beside the bed and move your legs. At least 2 to 3 times you move your legs. Once you move your legs, your calf muscles are activated. As and when the blood pools, the blood is pushed up. Then you start walking one by one. You put your steps, 1 step, 2 step, 3 step. So you set goal to the patient. You tell them today you come and sit here. Today you go towards door. Then you come out of the door. You walk half road like that. This is how you give them targets. And once they give the targets, they'll also feel happy that they're achieving it. So this thing is very important. So assisting in any way, if they're not able to walk, at least make them wheelchair mobilization. If they're able to just move out and feel their feet, that itself will make us happy, and the patient itself will get confident that they can do better than this. Okay? Next is very important about lines and tubes. Very much problematic things. That is why most of complaints or most of fight between us and sisters happen early in the morning is because of this. You can see all surgical onco, any sister in the ward from 11th floor to ground floor, first they will see coming to them is surgical onco people. First thing they come, sister drain, sister output, sister drain, sister output. So all the sisters they'll be having their own problems. Why it is important? I'm going to stress and tell you why it is important for us as surgeon and for you what you should look in drains and lines. So central line, peripheral lines. Managing a line is very much important. Whenever you have a IV line, peripheral IV line, always put a loop around that IV line. Put a single loop around that IV line. Don't leave it hang at the end of it. If you put one loop and plaster that loop, then that IV line is going to stay for at least 2 days extra than what normally it will stay. You imagine your 2 days you will get, because you have to prick that patient every alternate day if you are not going to secure the IV line. So just loop that IV line and don't put that pressure immediately where the IV line enters the vein. That's very much important. Second is managing central lines. Central line is like a lifeline for us, because any patient who undergoes HIPEC will not eat food at least for 4 to 5 days, and they will be on parenteral nutrition. So when they are on parenteral nutrition, if central lines are not managed properly, then they will develop fungal septicemias, bacteremias, central bacteremias that will prolong the hospital stay. Patient will not get cured. Patient will have so many problems because of this. So managing, although it is a very simple thing, but this decides patient will go home on day 8 or on day 16 or day 24 or day 40. This entirely decides. So it is very much important how you manage lines. If you don't manage your peripheral lines and central lines, even your life is also going to become very miserable. Taking lines is a very big task. Next, Ryle's tube. How many of you tell me want a Ryle's tube to be fixed like this on the nose? Lift up your hands. How many of you want yourself to be fixed lines like that, Ryle's tube? So the better way to put and fix a Ryle's tube is this. Okay? Try not to put too many things on the nose. It will pull them too much. Second thing, most of oncology patients, whenever tube is being put, Ryle's tube is being put, the Ryle's tube is stitched to the nose. Because we don't want, especially for few patients, the Ryle's tube to come out. Even accidentally also we don't want it to come out. So we stitch it with the thread and fix the Ryle's tube here. So many times I have told in ICU, lot many sisters also, in ward also. Whenever the tube is there, imagine I have stitched here, don't pull the tube and push it like this towards the same side. So instead, take the tube close to the nostril as much as possible. Whenever you see a stitch on the Ryle's tube, take the Ryle's tube close to the nostril and place it on the opposite side and stick it here. Don't put it on the same side and pull it this side. The more you pull, the thread is going to pull the nostril of the patient here more and more. So see to that you push the Ryle's tube towards the midline and the Ryle's tube is plastered accordingly. This is very much important. You can imagine yourself how much it troubles when Ryle's tube is not fixed properly. Okay? Next is about ICD care, which is a very big topic. Actually, Vijay sister is there here. She had asked us directly that we want surgical onco team to come and take one separate class for ICD only for our sisters. So much was the problem we had, in the sense like the fight that we had, that we want to manage like this, we don't want it to be like this, we want it like this. So the basic science is this. So you can see the air is entering, the air is coming out from the patient. This is the tube. So the air from the tube is going to come out here and is going to in the ICD bag. So the tube is below the water. Once the air goes down, then from there the air comes out. What are the two important things which is usually troublesome? One, try to keep the bag always below the chest level. Very much important. Otherwise, all the fluid from the bag will go inside patient's lung and the bag is, air is empty. So the patient is going to develop tension pneumothorax, or pneumothorax, it will become more. That is one. Second point, you have a knob to close the tube, ICD tube, so that the fluid doesn't move out. No, you have a tube fixing there. What is the importance of that one? When you keep it locked for a long time, the pneumothorax increases. So it is only when you are shifting for 5 to 10 minutes, immediately after shifting, your first thing that you remember is unlock it and see to that it is always under thing. This is about the ICD care. One more important thing about Romovac suction. So how do you unscrew the Romovac suction is very much important. Never ever unscrew a Romovac from this white cap. The moment you unscrew a Romovac from this white cap, it loses the screws and you cannot put it properly. If you cannot put it properly, the suction will not hold. If the suction doesn't hold, the purpose of putting the Romovac suction is lost. Okay? So anytime, whenever you are removing the Romovac suction, you have to always remove from this green cap. Always only remove the green cap, then empty the fluid. Never ever unscrew the white cap and remove it. It's very much important. Next is about drains. What is the importance of drains? For us, the quantity and quality both is important. If a person has got 20 ml today and tomorrow morning suddenly he gets 600 ml or 70 ml or 300, 400 ml, that should immediately alarm. We had many sisters who had called us immediately on the overnight telling, sir, drain looks not normal. There is so much fluid immediately. So if there is sudden change in fluid quantity is important for us. For us, more than quantity, what is important is the color in the bag. I have asked many sisters when I come, sister, what was the color? Immediately when the quantity is more, first thing I ask is, what is the color? Is any feculent material coming in the bag? Is any bile coming in the bag? Is any blood increasing in the bag? So what you have to see as a nursing when you are there is, when the patient comes first day, you ask the surgeon, doctor, why is it that the drain is placed? And where is the drain? Is it in the liver bed? Is it near the anastomosis? So if it is near the anastomosis, as and when if the anastomosis doesn't hold, if it leaks, immediately all the stool material will come out and it will come in the drain. That is what you have to see. So for us, it is not only about measuring the drain. Your duty is not to measure the drain. Your duty is to see what is in the drain. Is there any blood increasing? Is it bile? Is it stool? That itself will change. One hour of difference can make a life difference for the patient. Patient can immediately go to septicemia. Then about parenteral nutrition is about maintaining lines. This is also very much important. Same thing about lines. Then surgical site infection. I don't have to tell how good a team we have in surgical site, managing surgical site infections. Any small surgical site infection is a reflection of the quality of care that a hospital gives. As a team, we are very much proud whenever we present our papers in international forums. When we tell our surgical site infection is so low, they don't believe. Why is it that we have such low infection rates? Because of managing surgical drains, our Romovac suction. Second thing is, what is the care that we give? Even if single patient has got culture, sister immediately come next day to ask me, doctor, was there any symptom? Was there, how was the culture? Patient had fever. Did patient come and tell you? Our setup is so good that you follow immediately from the base. So we had in our hospital also, in our own OPD, we had 2-3 patients coming out MRSA positive. The culture was MRSA positive. We were not sure who was the source. Actually, it was one of our own doctors who had a MRSA in his source. So it was only because sister came to us, we sat and analyzed our own why patient is having, why we are getting MRSA culture suddenly, immediately. Then we checked lot of our patients. One of our doctors who had treated a patient who had MRSA infection, he developed MRSA infections. From his body, repeatedly we had many infections because he had done dressing to many people. So that is how you follow up. Immediately whenever something is there, you follow up subsequently. So at the time of discharge, you address all these things. When should a patient take bath? Can he sit? Can he stand? Can he climb the stairs? Can he eat something? Can he drink something? How far can he walk? Where can he sit? Can he have bath? Can he have head bath? Can he have put water on body? All these things very much important. And about nutrition. Can he eat tea, coffee? You tell them long list. Again they'll come and ask you, sir, can I eat this? Can I drink this juice? So it is never the ending. The more you tell, the more they ask. But you have to tell them. That's very much important. Then the follow-up care that happens in our OPD is unimaginable. Most of the work that we do as doctors is all managed by our OPD sisters. The drain care, removing the drain, the cultures, if any infection is there, even if mild redness is there. So all these small things, they just come and tell us immediately, doctor, this doesn't look like a simple drain, there is some redness, you please come and see, they tell us. So as a sister or somebody who is joining or bringing in your profession, these are the things that you have to notice, that small things, small redness or changing drain color, drain fluid, when you come and tell, when sisters come and tell, when we go back and see, it changes the entire scenario itself for the patient. So ultimately, last 2 more slides. So doing a HIPEC and about nursing is mainly about patient selection, how you treat a patient, how you prepare a patient, and how you prepare your team. It's always about the team. So preoperatively, as I told you, counseling, giving nutrition, indenting the proper drugs, taking care of the images that has to be taken over to the OT next day. Intraoperatively, what are the techniques that you have to prepare yourself by to avoid chemotherapy being contacted with you? How should you wear the gloves? How long gloves should you wear? How do you manage chemotherapy? If chemotherapy spills during HIPEC, how you should manage all those things. Then post-operatively, as I told you, all the things what I told you right now. So as I told, this is a slide that we put up everywhere. Anywhere in HIPEC we have presented till now in all over India and the world, our slide doesn't end without this slide. This slide has got all the team which performs so well, all those things, and I have left specifically one blank there because this blank is very difficult to fill. We know all of us are there around the patient, but the only person who is there with the patient is all of you. This is our Manipal nursing team. So all our results, we are very proud that we have established such a standard in HIPEC care in entire India and entire Southeast Asia. We have patients coming from Canada, from where everybody comes and asks us, how do you manage your patient? What is your protocol? What is your protocol? How do you manage in ward? How do you manage in ward? So it is all the efforts of such a good team that we have, that we are able to deliver at such standard of care. So telling thank you to all the nurses. I've told this before also, that doctors are told that doctors are the backbone of hospital, but for me, nurses are the backbone of doctors who can stand in front. It is all because of you that we are able to deliver. Thank you. If there are any questions, if you have, otherwise we can go for lunch.
Any questions? Thank you so much, Dr. Rohit, for a very informative session. I think HIPEC is something which is very new for many people, and you have reiterated on the best practices which needs to be followed in a daily routine, and that's something which is highly appreciable. Moving on to the feedback session, as we have come to the end of the conference, I would request Ms. Gloria to come forward and give feedback about the session from the morning, what all we had.
First and foremost, I would like to thank management. Took a opportunity to arrange a conference for all of us. It was really very good, and they have given opportunity for all of us to thank them, and how useful all the sections were. I would like to speak here. So this conference is really very helpful for all of us, and moreover the topics which has been taken by all of our doctors, I would like to share here. It is the first topic which has been taken by Dr. Shomshekar, surgeon. It is how is the eras, how it will be taking, what is the complication, how we can be, the patient can be short stay and they can go without any complication. That was very much good class, and we can able to understand how going forward how we can put into ourselves into the bedside work. That was really good. And apart from that, the Dr. Ashish spoke about febrile neutropenia. So regarding the children's, most of the children's, how it will be coming, and immediately starting the antibiotics and taking the cultures. Even it is very important when we are looking forward, when the patients are coming, within 60 minutes we need to start antibiotics. That was very helpful, and we will look forward and we will ensure that it will be done in the bedside as well. And apart from that, Dr. Mallikarjun spoke about the single most care which always our HIC people will be talking about, that is hand hygiene. It was really good, and we need to take care of our patients when we are putting the PICC line or the Bucklin dressing or chemoport insertion or handling of any of the surgical site or any dressings. It's very necessary to do our hand hygiene protocols and follow it as usual. So apart from that, the class which has been taken by Dr. Amit was care of pain. Actually, we used to take care of our patients with the care of pain. The most of the time, we will also forget what is the first medication, what is the second line medications. That was really good class, and we could able to understand how we can also help our patients in our life. Apart from that, Ma'am Poonam Patel has spoke about coping strategy. So far we were thinking that counseling and talking to the patients, not that only things will be helping. Apart from that, how we can help the people by writing the diary, play things, all those things, how we can express our pains. That was also very nice class. It was really good. All the classes were, I liked it, and all our friends whomever is here, they will also put into this one. And coming forward, and Ma'am Shraddha, it was nice class. You brought a person, it's your own father, and given a best example for us. It was really good. We understood with that positive attitude will help for our patients. Thank you, sir. So apart from that, Dr. Rokit has spoke about IPEC surgery, and nursing care is the most preferable care where we need to be very careful. That was also very good class, and we will looking forward, ensure all things will be put into the bedside. Thank you so much for management.
May I call Ms. Lintamol for about her feedback.
No, I think I'm tall enough. Yeah. A warm good afternoon to all of you, my dear professional colleagues and respected dignitaries. I will not take much time. I know that all of you are hungry. We can wind up soon. First and foremost, I would like to thank the entire management and the organizing committee, including Judith ma'am, for considering me as an observer for today's conference. I would like to appreciate Judith ma'am and the organizing committee for conducting an offline conference. I must specific on this offline conference because as I was listening to Dr. Pai in the morning, I think in North Bangalore, this is the first conference after 18 months which is conducted. So a big past 16 to 18 months, we are attending all webinars online. I don't know how effective it is, but I was very happy to come as an observer today for this offline conference. Thank you, ma'am. And yes, here I'm supposed to give the feedback about today's conference. I feel that the selection of the topics, it was excellent, and moreover, you all are lucky enough to get expert speakers from the field of oncology. And the topics also were very effective, especially like HIPEC surgery, which was new to all of us, not to all of you, but to me it was really new, and IRAS. Again, we expect more and more offline conferences from Manipal side, and we would like to have a close association with you people. Thank you all, and once again, thank you for having me here. Again, one more thing I would like to mention here. Each speakers, after their talk, they were mentioning about your Manipal nursing team. And again, we, the Koshis family, last month, we also experienced the same care and support from your entire team. Our MD was admitted for a few days on ventilator in MICU. The sisters like Pindo sister and the entire team, and including Judith ma'am, the support what we received, we would like to thank from our bottom of heart to the entire Manipal team. Thank you all. Keep up your good work. Thank you.
I would request Ms. Judith Wasan and the oncology champions to come forward to honor Ms. Linda Moll with the memento. Oncology champions. Thank you all. I would request Ms. Judith Wasan to speak a few words.
Sorry, I've kept you waiting so long for your lunch. We thought, okay, we can finish the morning's session, go for lunch, and then start off with the workstations. I hope all of you enjoyed today's conference, and I'm proud to say that it is the first state-level conference in Manipal MHB. Thank you. And for today's conference, we have been awarded 8 credit points, 6 credit points for the morning session, and 2 credit points because it is a workshop. And I think the workshop is also very significant because we have obtained consent from the patients for doing the video recording for various stations. And I am really thankful to the oncology champions for working at it along with the branding team. So let's give a big hand to the oncology team. I would like to thank finally Linda Moll for accepting and coming to Manipal. I have a long association with Koshi's College of Nursing, and many of our staff come here as interns and also as staff nurses across the hospital from Koshi's College of Nursing. They have been very significant in their nursing care, and always the HR every time tells me, why don't you get somebody from Koshi's? But you know, Koshi's College of Nursing also has an hospital attached, and I think they take all the prime people into their hospital, and the remaining people who are really interested to work in Manipal, they send to us, and we are very thankful to Koshi's College of Nursing. Thank you, ma'am. So, at last, wishing you all a very happy learning and I hope even the workstations gives you a good learning experience during the afternoon time. So we can break for lunch after this, and we can meet up with Archana will be telling you who are belonging to which group. So you will be moving in groups for the workstation. So team, please make use of this conference and improve your knowledge. At the same time, the knowledge has to be transferred into practice at the bedside. So please pay at 100% of your attention after lunch. Don't be sleepy, don't run away anywhere. So your attendance will be again taken for your practical sessions because we have to submit it to the Karnataka Nursing Council. That's why we have gotten your KNC numbers also. So please be there on time and be enriched by the practical sessions. Thank you, one and all. So I would like to give a thanks to all of you. Let's clap for ourselves who has come and attended the conference. All the educators, quality team, the DNSs, the nurse officers, the nurse managers, and all the staff nurses who have really made, and consultants, of course, who have also come as speakers, the weekend team, the B-Brawn team, which is at the back, and especially Darshan, for all the support, for the flowers which we see here, for the banner we see here, for the food we are going to have now. So thanks a lot to the B-Brawn team for sponsoring this program. Thanks a lot. Thank you.
So we have come to an end of the session. We will wind up for the lunch break. Request all of you to kindly move towards the lunch distribution area. And we will join back in 45 minutes.